On behalf of my colleagues at the Department of Pulmonary Medicine at the PGI Chandigarh, I welcome you all to this update on the COVID-19 pandemic. The number of participants at this stage looks fairly good enough, and I expect more of the registered delegates to join us soon. This webinar is organized under the aegis of the Academy of Pulmonary Sciences. The Academy of Pulmonary Sciences has been involved in promoting educational and research activities related to pulmonary medicine and allied sciences for the last almost a decade. The Academy has earlier organized and supported multiple workshops and seminars related to diverse fields such as asthma and COPD, interstitial lung diseases, ABPA, bronchoscopy, interventional pulmonology, and others. The Academy has also partnered with national and international professional organizations and contributed intellectually to formation of evidence-based guidelines as well as training modules on chronic respiratory diseases. Today's webinar will mainly provide a scientific update on the current paradigms for managing the basic disease and its complications in COVID-19 patients. We will also try to provide some guidance on issues related to respiratory comorbidities. For this, I and my colleagues have attempted to summarize the available scientific evidence in a meaningful fashion. As you are all aware, there has been an explosion of scientific literature on COVID-19 ever since the pandemic has unfolded. The PubMed database alone lists about 72,000 new citations in the current year itself, and not all of it is relevant or of good quality. We have tried to examine the important evidence to derive clinically useful practice points, both on what clinicians should do and what they should not. We have purposefully kept ourselves away from the large body of information available through WhatsApp groups, Facebook pages, and opinions expressed in the lay press. We hope you would approve of this. Today's program has been structured as a series of presentations on different topics, each lasting about 20 minutes. I would encourage all participants to submit their queries related to each presentation in the chat box. We will try and resolve the important questions immediately after each presentation within the broad constraints of time available to us. We also plan a panel discussion at the end where some miscellaneous and yet important issues will be taken up. Before we formally begin, I would also like to thank the team from Messrs. Boehringer Ingelheim for providing us the much needed logistic and financial support while organizing this meeting. I'm sure this webinar will provide a good forum to update knowledge on COVID-19, both for the participating delegates as well as for me and my colleagues here. Well, without further delay, let's start today's proceedings. I will now invite Dr. Inderpal Singh, one of our dynamic faculty who is actively contributing to COVID care at our institute, to discuss the pharmacological management of COVID-19 infection. Dr. Inderpal, please.
Just one announcement. Yeah, can you hear me, Inder?
Yeah.
There's one announcement for all the participants. As the lectures go on, you can type in your questions, which at the end of each lecture will be taken up by our moderators, Dr. Valiyappan and Dr. K.T. Prasad, and would be posed to the respective speaker. Thank you.
Sehgal sir, can I request you to make your slides full screen? Inderpal sir, can you hear me? Sir, it seems that Inderpal sir has logged out. Ashish sir, can you hear me? Sajal sir?
Yeah, if there are some technical difficulties,
I
then
think there's technical difficulties, sir.
maybe we can move over to the second talk and Inder can take up his portion next. Is that okay?
Sure, sir. I think that works.
We'll just take 2 minutes. There was some
Okay.
problem with this
Okay,
net
then
connection.
fine. Inder can.
While we start, sir, I can see a lot of my friends and seniors there. Good morning to everyone in the audience. I can see Aman. I can see Dr. P. N. Agarwal. Deepa is there. Dr. Dharmesh is there. Dharampal Bansal.
Am I audible?
Yeah, you're audible.
Yes.
In the loud and clear. Can you make your slides full screen?
Yeah, sure. So, good morning, my dear friends and colleagues. I am the leading batsman in today's webinar. I'm sure you've attended many webinars over the past few months, and perhaps you must be waiting for the department to come out with their own set of slides and lectures. So here we go. I'm going to talk about the pharmacological management of COVID-19. Well, I feel that this is the most important topic that we need to discuss. When the disease started, we hardly knew anything about the management of COVID-19, and in fact, we at PGI followed a very minimalistic approach. We rather would support the patients rather than treating them with too many drugs without clear evidence. As Dr. Ashutosh has already pointed out, there is a flurry of literature if you really look at the PubMed itself. So if you type COVID, one can see there are about 67,000 results that come up just by typing COVID. And mind you, we've not even completed one calendar year. But if you really look at the quality of evidence that has come up, and if you select the randomized control trials and apply that filter, you see that there are hardly good quality evidence that we have. Just 108 results, and mind you, not all of these 108 reports are RCTs. In fact, some of them are the clinical trial protocols, and some are not even randomized trials. So we have a very few good quality evidence with us to answer so many questions. Not only there is a flurry of data, there is a lot of patients. We also have a surge of COVID experts, from pharmacists to our surgeon colleagues to radiologists, who all are prescribing drugs. We have our own religious gurus and politicians telling us to give plasma therapy as if they are going to inject their own plasma. And some of the politicians even tell us to drink bleach. And mind you, many of our poor patients have done that and have suffered. And the list goes on. So before I proceed further, let me show you the definitions that have been used by the WHO and the clinical trials. So there is some difference in that. The WHO defines mild disease as asymptomatic, moderate as infiltrates on radiology and a room air saturation more than 90, severe disease as a room air saturation less than 90, and critically patients who have at least one organ failure and ARD, and they've used ARDS definition to define critically disease. Primarily, they have done so that the epidemiological data is robust. However, the clinical trials have used a different definition. Mild disease includes asymptomatic patients. Moderate disease includes patients with infiltrates on radiology, but a room air saturation of more than equal to 94. And severe disease includes infiltrates on radiology and a room air saturation of less than 94. So I'm going to really follow the clinical trials because that is what I'm going to show you. I'm going to show you the evidence. So this is a typical case that we see a 55-year-old gentleman with type 2 diabetes and hypertension, presents with cough, malaise, high-grade fever of 3 days duration. On checking his room air saturation is 96%. What we also do is we do exercise test and we see that his room air saturation in fact has improved after exercise. Although we don't promote getting any sort of radiology in this set of patients, most of us actually get not only x-rays but many of CT scans. And mind you, most of our patients are at risk of developing radiation fibrosis the way we are doing radiology every day. The other investigations, he had anemia and the NL ratio, so-called NL ratio was elevated. The D-dimer, the inflammatory markers you can see are all elevated. So let me ask you, what are you going to do? Most of us, and what I have seen some of our colleagues would write all this. I may be missing some of the options from the grocery list. I called it the COVID list. So you have the investigations which you want to do every day. You want to do x-rays, you want to give steroids, you want to give favipiravir, you want to give remdesivir, HCQ, azithromycin, ivermectin. Oh, the list goes on and I get tired. But what really should we be doing? What we do at PGI is we don't do anything. We just sit back, relax, just give symptomatic treatment and monitor our patients with saturation using a pulse oximeter if needed. So let me show you the evidence. People who use steroids, let me show you that this is the trial, the recovery trial, which has included more than 6,000 patients. And about 1/4 of patients in this recovery trial had no oxygen requirement. And I'm quoting the authors. We found no benefit and possibility of harm amongst patients who did not require oxygen. So mind you, using steroids in this set of patients who have normal oxygen saturation, that is more than 94% on room air, you might actually be doing harm. So the learning point number one is, do not use systemic steroids in patients with mild to moderate disease due to COVID-19, and use of steroids actually can do harm. The next drug which we want to use is, why not give some antiviral? Let's give some antiviral. So we have an antiviral which is called as remdesivir. And before I proceed further, this is the 7-point ordinal scale which most of the trials have used, starting from a low scale of 1, which includes not hospitalized patients, to a point of 7, which means that patient has died. So the trials have looked at the distribution of subjects in this ordinal scale and have done complicated analysis. But for me as a clinician, what is important? Is there any difference in time to recovery, clinical recovery, whether my patient will need oxygen for a lesser time or a lesser hospital stay? Importantly, no difference in mortality. So these are the outcomes that I as a clinician want, and this trial did not meet any of these trials, any of these outcomes. Importantly, there was no data on viral clearance. So you are using an antiviral agent and hope that it will enhance the viral clearance, and you have no data on that. So my dear friends, remdesivir does not reduce time to clinical recovery or worsening of patients or mortality, and hence it should not be used in group of patients who have mild to moderate disease, which means that they have a room air saturation of more than 94%. So remdesivir is an intravenous agent. I'm sure you would be tempted to use a drug which can be taken orally. So what harm can favipiravir do? This is yet another agent which has done a business of billions. And I'm sure most of us or your colleagues would have used this agent left, right, and center. But do you know the evidence behind it? So we have 2 RCTs, very small RCTs. This is one of the RCTs from Japan. So many of us tell us that the Japanese have been able to control the disease because they use favipiravir. No, my dear friends, they have been able to control the disease because they follow strict social distancing and use of mask and hand hygiene, which we do not follow. But anyhow, this is one of the trials from Japan, which included 89 subjects, and they randomized patients to receive either early or late therapy, which includes day of onset of symptom. And the outcome they looked into was the viral clearance on day 6, which was not different between the two groups. Importantly, this study did not have any control arm. So even if you don't give favipiravir, we don't know what would have happened. It also caused hyperuricemia. And this is another trial from Russia, which included 80 patients, and they randomized 1:1:1 in two different doses of favipiravir and compared it with the standard care. 2 patients, mind you, died in the favipiravir group. There was no difference in day 10 viral clearance between the favipiravir or the standard arm. And mind you, they have pooled the results of both the doses together. Despite that, there was no difference. And it caused significant side effects in 18% of your patients. So they would suffer, most of your patients are already suffering, they are likely to suffer more. So this is a meta-analysis which has included retrospective data and RCTs. In fact, this should not be done, but despite the flaws, this meta-analysis has also shown that favipiravir is ineffective in improving viral clearance, preventing clinical deterioration, or reducing the need of oxygen or NIV requirement. So my dear friends, I hope I have opened up your eyes and minds to show you that favipiravir is useless and should not be used left, right, and center in any of your patients with COVID-19 disease, except for in a clinical trial setting. So this brings us to the next widely advertised drug, which has been used is the hydroxychloroquine, chloroquine. One really asks, why not? Why should I not use? I've been using HCQ for many years in all of my patients. None of them have had any side effects. Well, let me show you the evidence. HCQ, in fact, has been tested in this trial, which included about 400 odd patients. And again, as you can see, there was no difference when you used HCQ in resolution of symptoms or clinical improvement on day 14. And this is a meta-analysis which has included all the trials which have been done in COVID-19 patients using HCQ combinations with azithromycin or without azithromycin. And as you can see on the left side of the panel, the use of HCQ across all group of patients has found to be useless. In fact, if you combine its use with azithromycin, it can increase the mortality. So combination of HCQ and azithromycin in fact increases the mortality. So HCQ has no role in mild to moderate disease due to COVID-19, and a combination of HCQ and azithromycin in fact increases mortality. So do not use this combination at all. So this is another interesting cocktail regimen that one sees, when somebody sends a WhatsApp message to you. One of my friends sent a prescription to me, and he had a list: ivermectin, doxycycline, zinc, vitamin C, and what not. And this ivermectin cocktail therapy has its epicenter in Bangladesh. So this study, which I happened to review, somehow it could not see the light to publication, has been published on Medrex, and this is a quasi-RCT. So the authors have randomized alternate patients to receive ivermectin combination on an outpatient basis. The study included only 30 patients, 15 in each arm, and they have given only a single dose of ivermectin, the rationale behind which remains unclear to me. They've also used doxycycline, again unclear rationale, and importantly it lacked a control arm which included giving nothing. And despite all that, there was no benefit of ivermectin and doxycycline. So the lead author, the first author is from Bangladesh, and importantly the corresponding author is from China. So they are publishing like that. So ivermectin has no role in management of mild to moderate COVID-19 disease and should not be used. So like I said, I've seen people prescribing zinc, vitamin C, B12, vitamin D, and whatnot. This is basically a WhatsApp propaganda. Mind you, there is no evidence behind it. So it should not be used. The next thing that people have been using, especially in the private sector, is the convalescent plasma and tocilizumab. So they have been using it without any clear-cut evidence. There are no trials, mind you, in this set of patients, and they in fact can cause harm. I will show you in my subsequent trials why these agents should not be used. So my dear friends, what should we use in mild to moderate disease due to COVID-19? The answer is a simple tablet of paracetamol. You should monitor your patient's saturation with a pulse oximeter. You may want to do a post-exercise test. Those with a post-exercise test fall off more than 4% on a pulse ox need to be closely observed, and you may want to hospitalize them if they stay away from a hospital. Importantly, do not complicate a patient's condition by administering drugs which have no rationale and perhaps can cause harm to the patient. So this brings to me the other type of patient that we see. This is a typical case of severe COVID-19 disease, a 65-year-old male again with hypertension, poorly controlled diabetes, presented with 5 days duration of symptoms, room air saturation of 82%, P/F ratio of 200, and this is the radiology that we see: bilateral infiltrates involving most of the lung, and IL-6 about 80, and all the inflammatory markers elevated here. And like I said, this is one of the prescriptions that I found for one of this kind of patients. You see solumedrol, Clexane, Dazac, doxycycline, Zincovit, Limc, and Levolid, Duolin, Furacort. Oh my God. Again, you can see the glossary list of drugs that we tend to prescribe. And this is one of the leading cardiovascular thoracic surgeon who's done that at one center. So what will you give? What should be given in these patients? Should we give them dexamethasone low dose, methylprednisolone high dose, or should we pulse them? Why not? We have various ideas in our mind, because when the disease started, we had absolutely no clue what was happening. And then we have a lot of options: convalescent plasma, tocilizumab, HCQ and azithromycin. I've already shown you the evidence, so I'll be skipping that part here. And finally, the role of anticoagulation, whether we should give therapeutic dose or prophylactic dose. So this brings me to the well-conducted RCT, although it had some flaws, but the author should be commended for doing an RCT and bringing out the results very quickly. And the authors included about 6,000 patients in this trial. There are few learning points from this trial. Although the overall effect of steroids was beneficial in patients with severe COVID-19, the benefit was higher in patients who required invasive ventilation as compared to those who only required oxygen. And the use of dexamethasone had reduced, it performed better in those who had symptom onset of more than 7 days. So symptom onset, patients in the second week of illness and those who required invasive ventilation showed better benefit. The authors have used 6 milligrams of dexamethasone for 10 days or less, or till hospital discharge, whichever is earlier. Many other authors have used, centers have used different doses of steroids: the high dose dexamethasone, low dose hydrocortisone, high dose methylprednisolone, except for the DEXA trial that I've shown, the recovery trial. Most of the trials individually have not found the benefit, but if you pull together all the results, steroids definitely have a role in management of severe COVID-19, and in fact are the only agents that are shown to reduce mortality. So steroids reduce mortality in critically ill patients with COVID-19 disease, especially those who require invasive ventilation. There is no evidence that a higher dose of steroid is better than a lower dose. The duration of steroid should be up to 10 days or till hospital discharge, whichever is sooner. So this brings me to the next agent which has been used and promoted and in fact has been widely tried in this setting. So we have a few RCTs of in this set of patients. We had the initial preliminary report of use of remdesivir, and this final report has been recently published, which has confirmed the findings of the prior trial that the use of remdesivir reduces the duration of symptoms. In fact, it reduces the time to recovery significantly, 10 days versus 11 days versus 15 days. However, there was no benefit in the mortality. Importantly, if you split the hair, you would see that it had no effect in patients who presented after 10 days of symptom onset. Those who did not require any oxygen support, again reinforcing the fact that it doesn't work in patients with mild to moderate disease. And also those who required NIV, HFNC or invasive mechanical ventilation. So it kind of reduces the, it's a very narrow spectrum of patients. Only those who are on low flow oxygen does it really work. And this is another trial which has compared 5 days or 10 days of therapy in non-ventilated severe COVID-19 patients, and it was shown that 5 days of therapy is as good as 10 days. So if we look at the evidence from the solidarity trial, which has included more than 10,000 patients, and in this trial they've actually practically ruled out all of the repurposed drugs, including remdesivir, SCQ, lopinavir, ritonavir, and interferon. And they have shown that none of these drugs really work in the COVID-19 disease. So my dear friends, no antiviral agent so far has shown to reduce mortality or need of mechanical ventilation. In my opinion, role of remdesivir is doubtful, and I personally feel it has no role, and I leave it to your judgment. So this brings us to the next thing that has been promoted by many of our politicians. In fact, it has now become a status symbol. I've taken plasma. Have you taken plasma? So this is one RCT. This was stopped prematurely because the pandemic ended in China, and this was from China and included about more than 100 patients, and they found no difference in time to clinical improvement or reduction in mortality. However, they did show that it resulted in earlier conversion of viral PCR. And this is a RCT which has been conducted at multiple centers in India, and ICMR took the lead, and in fact should be commended that they were able to bring out this publication, and in fact would bring various centers together. And what they have shown, and they included patients with a P/F ratio of 200 to 300, and they have shown that the use of plasma did not reduce progression to severe disease or all-cause mortality. However, they also showed that it could marginally increase the negative PCR at day 7. So the learning point number 9 is that convalescent plasma should not be used in the management of severe COVID-19 disease. This brings us to yet another agent which has been used widely, and again, this is the status symbol for doctors and not for patients. I have used tocilizumab. Have you used tocilizumab? This is the question that a lot of us ask each other, isn't it? So what is the rationale? Rationale is that in COVID-19, IL-6 levels are high. Oh yes, in any disease it will be high. Look at the IL-6 levels in ARDS patients which were managed previously. The levels are in the range of 238, 700, in fact, even in thousands. And what are the levels in severe COVID disease? Only up to 165. So my dear friends, IL-6 definitely will increase. In fact, all these inflammatory markers will increase in any infection because that is the body's response. And it has been shown that IL-6 actually has a protective role initially and enhances the viral clearance. So are we doing harm to our patients by giving an agent which may not be needed? But you would ask that these ARDS patients that you are showing, they were done previously. Why not show me the current evidence? So to answer that question, Blot et al., what they did in the same duration when we were seeing the COVID-19 pandemic, they included 36 non-COVID patients with CAP and 27 COVID-19 patients proven. And what they have shown is that the IL-6 levels are significantly higher in non-COVID-19 patients with CAP. So do we treat all our non-COVID CAP patients or septic patients or ARDS patients with IL-6 inhibitors? The answer is no. And the lower table that I'm showing is the data from one of our trials where we have measured different cytokines in our patients with severe sepsis. And here also you can see the levels of IL-6 that we have seen. So the evidence which was not there previously, we are fortunate that we have some evidence which has been published recently, and this trial included about 400 patients who were critically ill. Some of these patients also received steroids and remdesivir, and despite that, the inclusion of tocilizumab to all these drugs did not reduce intubation rates or deaths, and there was no difference in time to discontinuation of oxygen. And similar percentage of patient had clinical worsening at day 14. So none of the outcomes were achieved by the use of tocilizumab. But then you would tell me that yes, obviously you are using steroids. It will suppress all the inflammatory markers. Obviously tocilizumab will have no role in those set of patients. But let me show you this trial. This trial used only tocilizumab. None of the patients received steroids. And I'm sure you can see there is hardly any difference. So tocilizumab does not even work when used alone and not with steroids. But then you tell that why not use it early? Why not use it in mild disease? So this trial actually included patients who had a PF ratio of 200 to 300. So this, according to most of us, is mild ARDS. And even in this set of patients, tocilizumab was found of no use. Importantly, the Roche company has done an RCT. I'm sure you all are aware of that. And the results were published in the press way back in July. And why haven't they published their results yet? So I leave that for you to ponder upon that, why they still have not published. What I will tell you is that tocilizumab is useless and it should not be used as it does not reduce the mortality. It does not reduce the need for intubation or days on oxygen therapy. And it should never be used in patients who have mild disease. Okay. If at all you have to use, it should only be used in a clinical trial setting and not as a salvage therapy. This brings us to yet another important question. Should anticoagulation be used in patients with COVID-19 disease? The answer to this is that how is COVID-19 different? Except that we are seeing a huge number of patients. Mind you, this set of patients are similar to the critically ill patients that we routinely see. Evidence for use of anticoagulation, I'm afraid, is in the form of retrospective data. There are no RCTs. However, 22 RCTs are ongoing, which are comparing different doses of anticoagulation. One study, in fact, has compared prophylactic versus therapeutic anticoagulation, and it showed that the use of therapeutic anticoagulation reduced all-cause mortality. However, there was high risk of bias in reporting mortality in this trial, and there was significant higher bleeding events if you use therapeutic dose. So currently, there is lack of evidence to make us change, to make us change our existing practices. This is yet another trial in which they have followed their patients, both in those who have been admitted in ICU and those who are admitted in hospital, and the incidence of venous thrombosis is about 13% in ICU patients, and this is comparable to what we know in other critically ill patients, which is about 15%. And the two patients who developed venous thrombosis in the non-ICU patients had active malignancy, so they were at a higher risk of developing venous thrombosis anyhow. What this study also showed was that D-dimer levels at presentation did not predict the development of insidious venous thrombosis or the clinical outcomes. So based on this, what various experts, in fact, I'm just showing one of the consensus statement of one of the societies. There are many statements of different societies, and they all concur on this point that we should use standard dose thromboprophylaxis instead of full dose in all acutely ill, hospitalized and critically ill patients with COVID-19 disease. And there is no role of thrombolytic therapy for management of COVID-19 patients who do not have the clear-cut indication that is in massive pulmonary embolism with hemodynamic compromise. So nothing has changed. We should not change our practice about thromboprophylaxis. There is no role of antiplatelet agents in DVT prophylaxis. So many of our colleagues are also prescribing aspirin, clopidogrel, especially for patients who are not hospitalized at home. Mind you that the use of these agents can cause GI bleed and should not be used in fact. Importantly, what we also ask ourselves is whether should we give extended thromboprophylaxis after hospital discharge? The answer to that question is that the practice should be similar to what we do otherwise. If you think that patient is going to be bed-bound or have limited physical activity and has a low risk of bleeding, or he has other indication of extended thromboprophylaxis, only then we should use, otherwise it should not be considered. So my dear friends, thromboprophylaxis should be with usual dose of heparin. Here I would say that low molecular weight heparin generally is preferred over the unfractionated heparin. Full dose anticoagulation should only be used if you have clear-cut evidence of venous thrombosis or you have a strong clinical suspicion of some massive pulmonary embolism. Thrombolytic therapy should not be used except when it is to be used as we do normally. And one point which I must stress upon is that we should do active screening for ruling out DVT in our patients. These are the therapies which have poor quality of evidence or no evidence and should not be used in severe COVID-19 disease. That is methylpred pulse, thrombolysis with reduced dose anti-thrombolytic agents in those without massive PT. So what I have come across is that some of our colleagues use low dose thrombolysis in patients who have a D-dimer of say more than 20,000, 25,000. Mind you, there is no evidence. If you want to use, you do a clinical trial. Otherwise, don't use it. It can increase the chances of bleeding. Ivermectin, doxycycline, vitamin C, zinc, and vitamin D have no role. Intravenous immunoglobulins also have no role. Plasma exchange therapy, cytosorb therapy, and many other investigational therapies have no role unless proved otherwise. Some of the things what people ask, they get COVID disease, they get mild fever, and they get a panel of investigations done like CRP, D-dimer, procalcitonin, N by L ratio, LDH. What I would suggest you is that do not chase that. The trends of these parameters do not predict anything. In fact, we do not have any evidence on whether we should be using it or not. It has no evidence and no rationale. Anyhow, the treatment decision is based on whether patient has hypoxia or no hypoxia. So if he has hypoxia, what you are going to do? You are going to give steroid. If he has no hypoxia, you are not going to give steroid. That is the only thing that you should monitor. Management of non-COVID disease, importantly, should be as per the existing practices and should not change because of incidental detection of COVID-19 disease. So if you have to perform a procedure just because patient is COVID-19 positive, should not hinder his treatment. So my dear friends, to conclude, dexamethasone at a dose of 6 milligrams per day should only be used in hypoxic patients with COVID-19 disease for 10 days or less. Thromboprophylaxis should be given to all acutely ill and critically ill hospitalized patients with COVID-19 disease. Remdesivir, I leave it to your judgment, may be given in 5 to 10 days in patients with COVID-19 disease who have severe disease but not in mild to moderate disease. Tocilizumab should not be used. Investigational products should not be used out of clinical trial setting or till we have further evidence. So this brings me to the end of my lecture. I think we can take the questions now. Thank you for your patient hearing.
Yeah, there are few questions which I would like to start asking. The first question was regarding the use of NSAIDs and AKI. And the NSAIDs and AKI, there is no specific guidelines for use in COVID-19. As with any other NSAID use, in the patients with chronic kidney disease or ESRD, as the question was raised, you can use it with caution. And in 1 or 2 dosages, it should not make a material difference, and close monitoring is required. And regarding the anosmia, we do not know the exact mechanism, though olfactory nerve invasion and MRI involvement of the olfactory bulbs have been shown. So I would like to ask Inder sir for the questions regarding the steroids. So there are 3 main topics which have been raised in the chat box. The first is the difference between dexamethasone and methylprednisolone pulses. Is there a class effect, or what is the evidence and what is your opinion, sir?
I think the strongest evidence that we have is for the use of dexamethasone. There is another methylpred trial which has been published after the meta-analysis that I have shown, and there also methylprednisolone actually did not improve the clinical outcomes. So low dose steroid seems to be working here. Primarily, I feel because if we use high dose, we might be increasing the risk of secondary infections, and that perhaps increases the overall mortality. Although the meta-analysis did not suggest a class effect, but we can see that the trials which have used other agents generally at a different dose have not shown individually to have any benefit. But if we use low dose steroid of any class, I think it should work like in any other disease.
And the second
but
question
we should
was...
not be using methylpred pulses, high dose methylpred, because there is no rational and there is no evidence. If you want to use it, I would suggest that you should use it only in a clinical trial setting. Do not use it just because you think it will work. If you want to use it, you do a clinical trial.
Can I make a comment, moderators?
Yes, sir. Go ahead.
Yeah. So this is a usual question. What about dexamethasone? Can we use methylprednisolone, because we have been widely using methylprednisolone in asthma and other disorders. So if you go by the clinical evidence, dexamethasone 6 milligrams decreases mortality. It has not been shown in other steroids. It is likely that steroids have a class effect, but we don't know. So pending further evidence, if you want that your patient has a lower mortality, you should use dexamethasone at 6 milligrams. If you use any other dose, you are violating the trial conditions, and you may not actually replicate what the trial produced.
Dr. Inder, there are a lot of questions regarding convalescent plasma. I mean, people were asking whether antibody levels were done in the trials before harvesting the plasma. And the other question was whether convalescent plasma was given sufficiently early during the course of disease so that it could have really helped.
So early in the disease, so I would answer your first question. The antibody levels were in fact measured in the Chinese trial, but not in the Indian trial, which was in fact a pragmatic trial. Importantly, we don't know the antibodies that we measure actually are going to be protective or not. So use of plasma can also cause harm. So that is when we give plasma, we give IgG antibodies, and it has been shown that the antigen antibody can activate complement within the tissue. So if you give antibody from outside, antigen present in the lungs, they combine, activate the complement system and can cause further damage in the lung. So that is the harm with giving plasma. If you at all you have to give plasma, then you should give the IgG antibodies which exclude IgG4. So you should give other types of antibodies. The other question was, why not give early? So that is early. The early in the disease course they have given. So when the ARDS was mild, 200 to 300 is mild, and patients were given plasma within 24 hours of 24 to 48 hours of admission. You cannot give plasma to a patient who's sitting at home, isn't it? So patient has to come to you for whatever the duration of symptoms he's been having. So if you give the, that's what the trial from the Indian centers have shown, that even in patients with mild disease, which I believe is an early form of COVID-19, it did not prevent progression of disease to severe type of illness. So it has no role based on the current evidence that we have, and it should not be used. In fact, patients are made to run from one place to another to arrange for plasma. When the form of therapy has shown to be ineffective, we are making our patients run here and there just to arrange plasma. And in fact, I'm sorry to say that it has become a money-making thing in the private sector.
So there is another interesting question regarding the role of steroids. In the Solidarity trial, the median day during which it was given was 5 to 7 days. So is there a role of early steroids in mild to moderate disease was raised by someone?
So I've shown that if you use steroids in mild to moderate disease, the trial investigators themselves told that it will do harm. So you should not be using steroids there. I showed you in the recovery trial, we have done that. If you give steroids to them, it would do harm. Don't give steroids to patients who have mild disease. For patients with overall, the steroids did show benefit. If you look in an overall population, it in fact reduced the mortality in the recovery trial. But the benefit was more profound in patients who had illness in the second week of who were in the second week of their illness. This is what I was trying to tell you. Whether early or late, if patient has hypoxia, you should give steroids.
Since we are running out of
and
time.
Importantly, I would also like to tell you that we are in the recovery trial, the steroid arm patients did not receive any antiviral agent. So the concern that if you give steroids will enhance viral replication and cause damage, perhaps if we take it from this recovery trial, would not suggest that at a dose of 6 milligrams per day.
So, since we are running out of time, we will take up the questions.
Now I would invite Professor Ritesh Agarwal, who's a lead scientist, pulmonologist in India, and has recently been awarded Saroop Bhatnagar Award. And with this, I invite Professor Ritesh Agarwal. He will be talking about ventilatory management of patients with COVID-19 disease. Sir.
Yeah, thank you, Inder. Good morning, ladies and gentlemen. I hope I am audible. This care is always there, whether you're audible, you're visible or not, in this webinar kind of things.
So you're audible and visible, sir.
Yeah, thank you. Okay, so we'll be shifting gears now, and we'll be moving to the ventilatory management of patients with COVID-19. Inder has provided a comprehensive summary of the pharmacological management, and I'll try to briefly touch the ventilatory management. Yeah, so we'll be discussing the conventional oxygen therapy, high flow nasal oxygen, invasive, non-invasive ventilation, and certain adjuncts such as prone positioning and extracorporeal membrane oxygenation. So I think everybody is aware of this editorial, which came early in the course of the pandemic, that COVID-19 pneumonia has different phenotypes and they require different respiratory treatments. So the authors propose that the COVID has an L phenotype and an H phenotype. So the L phenotype is characterized by normal compliance, and there you can use oxygen, NIV, high flow nasal oxygen. And the authors in fact said that you could use high tidal volumes here. And on the other hand, we have the H phenotype, which is characterized by low compliance, high right to left shunt, and which should be treated as severe ARDS. And believe it or not, many centers started using this as a gospel. They thought that actually the COVID pneumonia has an L phenotype and an H phenotype. Fortunately, there were several researchers and investigators who were studying respiratory mechanics in COVID and non-COVID ARDS. And they found that the mechanics in COVID and non-COVID ARDS were similar, that there is no L, no H phenotype. ARDS, as we know, is a heterogeneous condition which always had this different kind of patients, and they suggested that please stick on to the ARDS guidelines, don't try something stupid. And in fact, a group of authors said that this L and H phenotype is a peril of a premature phenotyping, and they called a caution on believing this. So the most important message from this discussion is that ARDS in COVID is not different from a non-COVID ARDS. So what is the airway and alveolar biology in classical and COVID ARDS? Mostly it is similar. You can see this beautiful picture here that the biology is mostly similar. What is different is you have the viral particles which are there in COVID-19 ARDS and a slightly higher incidence of thrombus here. So this is what is slightly different between the COVID and non-COVID ARDS. You have decreased interferons. Somebody was asking a question, how can you predict somebody who's going to have a severe outcome? People are working on this, and there is some evidence those who have anti-interferon antibodies or those who have defects in their interferon response are more likely to develop a severe COVID. So the key pathophysiological features of COVID ARDS is similar to a non-COVID ARDS and is characterized by decreased pulmonary compliance, the presence of significant shunt and ventilation perfusion mismatch. So once the patient becomes hypoxic, the first step in managing any COVID patient is oxygen therapy. So you start with the conventional oxygen therapy with nasal cannula, and you can give up to 5 liters per minute, because after that the patient is unlikely to tolerate oxygen therapy through a nasal cannula. If the patient is still hypoxic or hypoxemic despite nasal cannula, you could move to either a Venturi mask or a non-rebreathing mask. We generally use a non-rebreathing mask. Please know that the target SpO2 is about 88 to 92%, and try to decrease the oxygen as fast as possible, because you will be causing oxygen toxicity, which may be one of the very important causes of post-COVID, fibrosis, etc. That we are giving high concentrations of oxygen for prolonged period. Nobody is closely monitoring this patient. So keep your target SpO2 at about 88 to 92%. Once we have given conventional oxygen therapy and the patient is still hypoxemic, you can move to high flow nasal oxygen. So what is high flow nasal oxygen? This is a high flow oxygenated gas which is heated and humidified, delivered via a special nasal cannula at flows of 40 to 80 liters per minute. So the crux here is you are delivering high flows which match the inspiratory flow rates of the dyspneic patients. So the dyspneic patients have flow rates anywhere between 50 to 80 liters per minute. So once you give high flow nasal oxygen, you match the flow rate and you decrease the breathlessness in that patient. Because you're giving high flow, the air entrainment and dilution of FiO2, which would occur with a low flow system like the Venturi mask or the non-rebreathing mask, is minimal with HFNC. Further, the expiratory impedance, which is created by the high flow, also creates a kind of an auto peak, which is roughly equivalent to 1 centimeter of water for every 10 liters per minute of flow after 40 liters. So if you're giving 80 liters, you're roughly giving about 4 centimeters of peak. So this is another advantage of giving high flow nasal oxygen. So the other modality which is used is the non-invasive ventilation. And I'm sure everybody knows that this is application of ventilatory support without the need for an invasive endotracheal airway. It has a physiological rationale in patients with acute hypoxemic respiratory failure and ARDS. The inspiratory positive airway pressure, or the IPAP, increases the tidal volume, unloads the inspiratory muscles, thereby decreasing the inspiratory load. And because it decreases the respiratory rate, it decreases the rate-related autopeep. The expiratory positive airway pressure, or EPAP, prevents microatelectasis and increases the functional residual capacity. The more important part of EPAP is the prevention of alveolar derecruitment, which is also known as atelectotrauma. So there is a physiological rationale for using NIV in acute hypoxemic respiratory failure. Now let's see the evidence. So this is a systematic review and meta-analysis published about 5 years ago. And this shows that the use of NIV in acute hypoxemic respiratory failure, or ARDS, significantly decreases the intubation rate as well as the mortality. So there is a definite role for NIV in such setting. What about the more severe forms of respiratory failure characterized by ARDS? So here there is evidence to suggest that the use of non-invasive ventilation decreases the intubation rate, and there's a trend towards decreasing mortality with the use of NIV, but it is not statistically significant. And this is a systematic review and meta-analysis which we did about a decade ago. So these are all observational studies which have looked at the intubation rates and mortality in ARDS. And if you use NIV in these unselected patients, you can decrease intubation in as many as 52% of patients. So NIV has a definite role in AHRF and ARDS patients, and it can prevent intubation in 50% of patients with ARDS. Now, how to choose the patients who are likely to benefit with non-invasive ventilation? So you choose your patients judiciously. You choose the patients early. So you choose patients with the mild ARDS who have no major organ dysfunction, no hypertension, etc. Do not require renal replacement, where you can have fluid shifts and changes in the sensorium and so on and so forth. So you use in patients who have mild ARDS and who have no major organ dysfunction. The use of BiPAP is preferred over CPAP. Use of a critical care ventilator which has an inbuilt oxygen blender is preferred over a dedicated non-invasive ventilator. So these are all the routine things which we do in the ICU. You position the patient with head elevated. The interface is very important. Please do not use a nasal mask. You use either an oronasal mask, or better still, if you have a helmet mask, use a helmet mask. Now, how do you start with this non-invasive ventilation? So first, you don't strap the patient immediately. Just hold the mask to his face. Start with an IPAP, an EPAP of 8 by 4 centimeters. Increase IPAP in increments of 2 to 3 centimeters. So your aim is to achieve a tidal volume of about 6 ml per kg and a respiratory rate of about 30 to 35 per minute. And you increase EPAP again by 1 to 2 centimeters increment. And your aim is here to maintain a saturation at about 92% with the lowest FiO2 possible. Again and again, I'm stressing on the lowest FiO2 possible because you will be promoting oxygen toxicity if you don't take care of that point. Now, you cannot go on with this trial forever. So you reassess the patient after 1 hour. If the respiratory rate has increased, the pH has stabilized, the PO2 FiO2 ratios have increased, If the patient was hypercapnic, his PaCO2s have started coming down, then you can continue. Otherwise, you have to move to the next level. So there are certain predictors. For example, once you start the patient on NIV, and if the PO2 FiO2 ratio is less than 146 after 1 hour, that patient is very likely to have a failure of NIV trial. So those are the patients you should be watching carefully. And once you have given NIV, once the patient has started improving, you will obviously wean the patient off NIV. In the COVID pandemic, we had an interesting concept of what is known as awake proning. So this awake proning is a patient who is conscious and can be self-prone, and this can be combined with your oxygen therapy as well as NIV. So what are the advantages of a prone positioning? A prone positioning makes the ventilation more homogeneous by reducing the difference between the dorsal and ventral pleural pressure. We all know as respiratory doctors that the perfusion is always gravity dependent. So the perfusion will be more in the bases compared to the apices, will be more in the ventral than in the dorsal if the patient is supine. But that is the beauty of prone positioning. In prone positioning, the perfusion is uniform for reasons which are not very clear. That perfusion becomes uniform. It is not that once you lie prone, the perfusion is more in the dependent areas. It becomes more uniform. So the ventilation perfusion ratios become matched. So there is a significant benefit of prone positioning. Now, as Inder has said, we have a knowledge explosion, and there are now proper guidelines for this awake or conscious proning. And fortunately, these are quite simple and intuitive. Awake proning should be performed in patients who obviously require oxygen and not in those who do not require oxygen. So if the patient requires oxygen by nasal cannula, which is about 4 liters or more, you can also prone that patient. Patient should be having a normal mental status, should be able to follow instruction, because this is self-proning. So patient should be able to follow instructions, and he or she should be able to tolerate changes in position. The patient should be able to tell somebody that he needs to be again, from prone needs to be supine if he is not able to tolerate. So he should be able to call for help. And in general, we would prefer that the patient is able to self-prone or change the position with minimal assistance. And whatever which are not the indications, become the contraindication. So if you have normal oxygen saturation, altered mental status, inability of the patient to independently change the position or tolerate the positional changes, hemodynamic instability, inability to follow instructions, and in settings where the patient cannot be closely monitored, awake proning should not be attempted. So what is the evidence of awake proning? It is widely used in ICUs, but the evidence is quite sparse. If you look at the literature, they have used various protocols from as little as 5 minutes to as high as 3 hours. And the success rate has varied anywhere from 25 to 50%. In some patients, that all patients had improvement, but then they were also getting NIV. So we are not very sure what is the current positioning of awake proning, but because it's a harmless kind of thing and there's a significant increase in oxygen saturation in most patients, so you can try awake proning in patients who require either conventional oxygen therapy, high flow nasal oxygen, or NIV, and the patient is still hypoxemic despite these measures. This is one important thing which I think as a critical care physicians we need to remember. Whenever you use non-invasive modalities in patients with the acute lung injury and ARDS, there's a potential for what is known as PSILI, patient self-induced lung injury or effort-induced lung injury. So if the patient who is on oxygen, NIV or HFNO has respiratory distress, his breathing pattern is not good, then there is no point continuing that modality for long. You give a trial and the patient is not improving, you move to the next level. So please, this is the second most important message from today's discussion. First being that COVID is not different from non-COVID ARDS. Please don't continue the patient indefinitely on non-invasive modalities. If the patient is not improving, is having respiratory distress, I've seen myself patients being given HFNO for 2 weeks and then being intubated. This is poor critical care science. Please move to the next level early. But this doesn't mean that you directly intubate all the patients. You obviously will move in a stepwise fashion, and I'll come to that shortly. Because as in the words of Dr. Martin Tobin, the surest way to increase mortality in COVID is indiscriminate intubation and mechanical ventilation. So we obviously will not directly jump to the big gun, which is invasive mechanical ventilation. In the last 3 decades, what we have learned in ventilation of ARDS is the most important thing which we should not be doing is causing ventilator-associated lung injury, because this is an important cause of poor clinical outcomes in ARDS. And the principal causes of VALI is alveolar overdistension and cyclical atelectasis, so-called the volutrauma and atelectotrauma. So how can we prevent alveolar overdistension? By using low tidal volume. And how we can prevent cyclic derecruitment or atelectotrauma is by using an optimal level of PEEP. So we'll come to the landmark trial, the ARMA trial. Many of you will know the expansion of ARMA. Many of you may not know the expansion of ARMA. ARMA trial came from the KARMA trial. So we had the initial trial, which was ketoconazole and respiratory management in ARDS. So we had ketoconazole and this in a trial. It was a composite factorial trial. What they found after a couple of years was that ketoconazole was not effective in ARDS. So they took off ketoconazole, and the KARMA trial became the ARMA trial. So in my personal opinion, this is one of the landmark trials in critical care medicine. And I think if we follow this trial to the T, we are going to cause much benefit to our patients. So the protocol is simple. You start with 6 ml per kg of tidal volume. You give PEEP according to the FiO2 requirements. The goal here is a plateau pressure of less than 30. The PO2 can be maintained between 55 and 80 pH to above 7.2 and so on. And it's a very simple kind of protocol. And it should be used in all the ICUs, all the patients with ARDS as a rule. There is no running away from the ARMA trial and the low tidal volume ventilation strategy. Is it useful? Obviously, it is useful. Look at the mortality. If you treat 12 patients with low tidal volume in comparison to your other modes of ventilation, you're likely to prevent 1 death. And please note the unintended the benefit. It is, I think it will be as good as tocilizumab, or I think better than tocilizumab, because it also decreased the plasma IL-6 values. So you are giving the benefit of tocilizumab to your patient for free once you're using the low tidal volume ventilation. And if you use this, the long-term outcomes are also good in patients with acute lung injury. So the other important question is, once you have used a low tidal volume, how to set PEEP? So the ARMA trial used what is known as the low PEEP kind of strategy. And the rule of the thumb is, whatever is your FiO2, the 20 times is the PEEP. So if your FiO2 is 0.4, PEEP is 8. If your FiO2 is 0.7, it's 14, and so on and so forth. So this is how we remember it as a rule of the thumb. You have another strategy known as the high PEEP strategy, which uses this kind of algorithm, and this can be easily remembered by using this stuck in your ICU. You don't have to memorize these values. So where are we going to use the high PEEP approach? So the high PEEP approach can be used in patients who are still hypoxemic with your low PEEP approach. So with a low PEEP, if the patient is still hypoxemic, you can move to the high PEEP approach. And these are likely to be patients who have severe forms of lung injury, like the ARDS with the PO2 FiO2 less than 200 or 150. And these are the settings where the high PEEP approach is likely to be beneficial. So now coming to the adjunctive strategies, the first is prone positioning. This is a very important trial, the PROSEVER trial. This used prone positioning sessions of at least 16 hours, or they randomized the patient to the conventional supine ventilation. Please note, they used the low tidal volume strategy of the ARMA trial, and their inclusion criteria was a PO2 FiO2 less than 150 millimeters of mercury with an FiO2 of at least 0.6. And look at the results. Mind-blowing. 50% decrease in mortality. Straight, 33% to 16%. So prone positioning is good clinical medicine and should be adopted if the patients are hypoxemic despite your low tidal volume strategies. Which group of patients benefit? Only those who have proning for at least 12 hours. The PROSEVER trial used 16 hours. A meta-analysis said, okay, if you use for at least 12 hours, the patient is likely to benefit. Less than 12 hours, if you do, the patients are unlikely to benefit. Will all patients with ARDS benefit? They said no. Only patients with moderate to severe ARDS will benefit from this prone positioning strategies. And at least in our ICU, it's a norm. I mean, it's a protocol that the patient is not we are not able to manage him with low tidal volume strategy. Then the next step is prone positioning. This is the in thing rather. If you see everywhere, you have ECMO societies, ECMO, SHECMO, everywhere. The ECMO is patients are getting transplanted on ECMO and so on and so forth. And I'm all in for ECMO, but there is a little caveat. I'll come to it shortly. So ECMO is venous blood which passes through a membrane oxygenator and it is returned to the arterial circulation. This is a veno-arterial ECMO. You also have a veno-venous ECMO which is associated with lesser complications. And it obviously will support gas exchange in patients failing conventional ventilation techniques because you are extracorporeally exchanging the gases. So you have two major trials, the CESAR trial and the Airway trial. These are the basic baseline characteristics of the patient. The PO2 FiO2 when they included the patient was quite low. And if you include the trial individually, the trials did not decrease the mortality. But if you club both the RCTs, there is evidence that the mortality is decreased, and this is a independent data meta-analysis recently published, which showed that the time to mortality also is significantly decreased in patients with ECMO. Am I an ECMO buff? Maybe I am, but not before prone positioning. So this is ECMO in COVID-19. The article said that only 37% died. So everybody thought, oh, good, ECMO, 37% mortality only if you use ECMO in COVID. That is not the exact figures because the article did not provide the final data at 90 days for a significant number. More than 50% of the patients were either still on ventilation or were still on other kinds of support when the data was published. So we really don't know what is the actual mortality with ECMO in this study. And this is what I was alluding to when you're using ECMO. This is a very interesting article which said unproven and expensive before proven and cheap. ECMO versus prone positioning in ARDS. So this is a very interesting and intelligent analysis performed by the authors. They examined published reports on the use of ECMO in ARDS. So the basic logic being obviously any patient being likely to be placed on ECMO should be given a trial of prone positioning, because by the time you are planning for ECMO, at least give him a prone positioning. So what the authors found, of 17 papers that reported on ECMO, only 208, or one-third, less than one-third of the patient received a trial of prone positioning before ECMO. And interestingly, the prone positioning before ECMO was lower in studies published after 2013, meaning that despite the PROSEVER trial, the ECMO was used before prone positioning. And this was more after 2013. So the authors, it's a kind of a conspiracy theory that to bring out the benefit of ECMO, people are not using prone positioning. So I don't agree to the conspiracy theory, but yeah, I have some beliefs in the conspiracy theories. So what are the ICU outcomes if you use all these kind of modalities? So this is again a systematic review. Oh, there is a knowledge explosion of systematic reviews and meta-analysis following COVID. It is impossible to keep up with the literature. Now look at this table. Still in ICU. 56% of patients were still in ICU when the studies reported their outcomes. So we really don't know in all these studies whether the outcomes are good, bad, or ugly. To my knowledge, this is one of the best studies published on COVID, which describe the case characteristics, the resource use, and outcomes in a large data set from Germany. So they had 10,000 plus patients, of which 83% were managed without ventilation, and the remaining were ventilated. The mean duration of NIV was about 3.6 days. Mean duration of invasive mechanical ventilation was 17 days, and not different between those who died and survived, meaning that patients are requiring longer periods of invasive mechanical ventilation in COVID. Now let's see the mortality. In this study, only 3% of patients had no data while the study was when the study was published. So the overall mortality in the German ICUs was about, in the German hospitals, was about 22%. In patients who had no mechanical ventilation, it was about 16%, and those with mechanical ventilation, it was about 53%. Invasive, 53%, non-invasive, 45%, and non-invasive failure, 50%. So please, let's not have an NIV failure once we try to intubate. Let us do it much, much earlier. The patients on dialysis and ECMO, close to about 70% mortality. So this is another important point. If your patient of COVID develops renal failure, is likely to have a very poor outcome, especially if he requires dialysis. Try to prevent renal failure. That is a very important message from this article. ECMO patients will have poor outcomes as shown in the study, and was expected. And all the mortality parameters are higher in patients who are elderly, which is seen in this histogram. Here you can see that in patients who do not require ventilation, 34% will have mortality if the age is more than 80 years. So this brings me to my summary slide. So how do we manage patients? So first step is oxygen supplementation with nasal cannula. If the patient is worsening, you can either use venturi mask or non-rebreathing mask depending on your center. If you have HFNC available, move to HFNC if the PaCO2 is less than 45 millimeters of mercury. If the patient is hypercapnic, I personally feel NIV is likely to be more useful there. When will I move directly to HFNC or NIV? If the patient has respiratory distress. So the more important thing is, if the patient has respiratory distress on nasal cannula, please don't wait, because you may be unknowingly promoting the lung injury by easily. So if the patient has respiratory distress, move directly to second step. And if the patient is still having respiratory distress despite NIV or HFNC, try awake proning. If not, move to the next level, which is invasive mechanical ventilation. Please follow the ARDS net guidelines of the ARMA trial. High PEEP strategy can be used as a rescue. Prone positioning and ECMO are other strategies for rescue, and always prone positioning before ECMO. Thank you, ladies and gentlemen, for your kind attention, and I'll be happy to take up some questions if there are.
Sir, since we are running short of time, we'll have one quick question, which is a common feature in many of the questions you have been asked. One is regarding the happy hypoxemia, which has become talked during this COVID ARDS. And second is, there is a still opinion that COVID ARDS is different, and the complaints in this, as per the experience of several people in the chat, is different from the non-COVID ARDS, which they had been dealing with previously.
I have just one comment from this. It may be a little critical comment, but you know me. I'm always in for the critical part of it. So if the people feel that the COVID ARDS is different from non-COVID ARDS and they are not ready to believe the literature, please publish. There's a very famous saying from one of my close friends, Dr. Atul Mehta, Jungle mein mor nacha kisne dekha. You know, you think that the mechanics are different, please publish first, because the published literature does not agree with you. The mechanics in COVID ARDS is not different from non-COVID ARDS. So if you feel they're different, please publish. It's likely to be a good publication in at least Lancet, BMJ or NEJM. Any other questions, or shall we move to the next thing? Moderators.
I think we have exceeded by 10 minutes, so we'll move on to the.
Yeah, we can take a question at the end, I think, isn't it? So if there are no, if we are running, as we are running short of time, let's move to the next part of the discussion, which is on a very interesting topic, and which most of you are eager to hear, is post-COVID lung fibrosis. And this will be delivered by Dr. Sejal Duria. Sejal has interest in interstitial lung disease, and his research area is also interstitial lung disease. Sejal, please.
Thank you, sir. Prashish, can you hear me?
Yes, sir, we can hear you loud and clear, sir.
Yeah. Can you see?
Loud and clear.
Can you see me? Can you see my screen, full screen?
Yes, yes, all
Okay.
bright as you.
Right. Thank you so much, sir. So we have heard Dr. Inderpal and Dr. Ritesh and about the pharmacologic and ventilatory management of the acute COVID-19 pneumonia. And there has been a lot of evidence that has been generated on acute COVID. But now, as the pandemic progresses and there are more and more cases of acute COVID disease, what we are encountering are the COVID sequela, which is also called the post-COVID diffuse lung disease. And believe me, there are so many other sequelae in other organ systems, like persistent fatigue and other organ system abnormalities. But what we are going to focus on today is on the lung abnormalities that occur as a sequela of acute COVID-19 pneumonia. So the outline of my lecture would be, it all lies in the name. Let me define it. I'm suffering but getting better. I see black and white. Nestle, Maggie, hot and sweet, tomato chili sauce. It's different. All that glitters is not gold. The curious case of disappearing fibrosis. Does your argument hold water? Tug of war. Once bitten, twice shy. How to monitor and treat an eye work with a Bhatnagar body. And don't be scared that I'm going to read a chapter from an English literature book of 8th standard. I'll soon come to the science part of it. So it's all in the name. So what name should be given to this lung abnormalities that arise as a consequence of acute COVID pneumonia? The most common term that is being used today is post-COVID fibrosis. Other terms which have been used are post-COVID interstitial pneumonia and COVID interstitial lung disease. I do not agree with the first term, post-COVID fibrosis, because a lot of the lung abnormalities that occur as a sequel of acute COVID pneumonia do not represent fibrosis. I'll elaborate on this during the course of my lecture. Post-COVID interstitial pneumonia is also not a good term, because pneumonia is generally a term for the acute part of the disease, and this disease, including the acute and COVID features of the disease, are not limited to the interstitium. They occur in the alveolar compartment and might also involve airways and especially the pulmonary vessels. So the favored term that we use in our department is post-COVID diffuse lung disease, or PCDLD. Let me define the other terms, the terminology that is being used the world over. One is post-acute COVID-19. So this is a term given to the period in a patient's course that occurs beyond 3 weeks from the initial onset of symptoms. And during this stage, resolved in most of the patients, but we do see certain severe patients who remain on oxygen and even on ventilation even beyond this time period. The chronic COVID-19 disease is the phase of the disease which extends beyond 12 weeks of the onset of symptoms. And these are provisional terminologies proposed by leading experts. The next thing is, I am suffering but getting better. So once a patient recovers from acute COVID-19 and is discharged from the hospital, several of them would have certain ongoing symptoms, including respiratory symptoms like cough, exertional dyspnea, and especially fatigue. There is a dearth of studies, but we have about 4 to 5 studies which have looked at the prevalence of these symptoms. And they mostly show that as time progresses, so a 1-month study showed that 74% of the patients discharged had exertional dyspnea, but a study done at 3 months showed that only 15% of these patients now had dyspnea. So over time, symptoms do persist, but the proportion of patients suffering from these symptoms definitely comes down. So patients keep on improving with time. The lung function abnormalities. So a study which looked at the lung functions, especially DLCO and FVC, 30 days after discharge had a high proportion of patients having abnormal DLCO. But at 3 months, the proportion falls down to about 15%. So we understand that lung function also improves. That is, the lung physiology also improves with passing time after recovering from an episode of acute COVID-19. Now moving on to the crux of the matter, and which is the radiologic imaging. And for that, we require the blacks and whites, the grays of the HRCT chest. So as we all know, the predominant lung abnormalities on HRCT of the chest in the acute phase mostly involves ground glass opacities and patchy consolidation. In the early phase, these are the 2 predominant abnormalities, but as the time progresses, as the patient goes into the 3rd and 4th week of the illness, certain other abnormalities like reticulation may appear, and rarely one might encounter traction bronchiectasis or traction bronchial ectasis, but honeycombing is distinctly rare. There are only a few case reports with this flurry of publications, thousands of publications on COVID. We just have very few case reports which have reported honeycombing, and in our clinical practice also, we have not encountered any honeycombing. So next, one has to make a distinction between the type of abnormalities. So I'll not too much talk about the acute COVID stage, but during the chronic stage, during the post-acute period, we have to make a clear distinction between the types of abnormalities that we encounter. So some of these abnormalities would resolve, but some would evolve. The same CT abnormalities may represent different pathologies. And how to know that, for example, a ground glass opacity in the acute stage would represent edema infiltration. With time, it might progress to consolidation with alveolar filling, and then the hepatization process occurs, and finally it resolves. But the same ground glass opacity in a patient with a chronic interstitial lung disease might represent fibrosis. So in the context of COVID, the clinical severity may be a good clue to what the CT abnormalities might be representing. So this is an example of a ground glass opacity. There's a unifocal GGO, a very classic sign of mild COVID generally. And such kind of ground glass opacities generally resolve over time, over a period of mostly initially 2 to 3 weeks in the mild cases. Even consolidation, which may occur as a peripheral patchy consolidation, but might be multifocal, it may initially evolve to give rise to a reverse halo sign where there is consolidation surrounding an area of ground glass opacity. But with passing time, even this consolidation keeps on resolving. And all these images are from an excellent study from China, who have performed CT scans in some of these patients during their hospitalization and have come up with these sequential CT images of different kind of abnormalities. Even reticulation. So this is a patient where there is this kind of a band and this kind of a coarse reticulation or interlobular septal thickening, and this also resolves by day 18. So this kind of reticulation also might not represent irreversible fibrosis, but something else. So taking a cue from the Chinese study, this is a patient that has been discharged from our ICU just a few days back, and he has this patchy consolidation in bilateral lower lobe. So the predominant abnormality is consolidation. The patient is not desaturating on walking. He has a normal resting saturation. So taking a cue from the Chinese study, I would expect that this consolidation would resolve over time and the patient would completely recover. Because we saw the rising phase of the pandemic later in Chandigarh, I do not have the follow-up data of these patients. And many of these patients would complete their 6 weeks follow-up this month itself, when I'm going to get the repeat CT imaging. This is another of our patients. This is day 2 of illness, when he had mainly ground glass and patchy consolidation, peripheral and peribronchial. This is again ground glass opacity, peripheral ground glass opacity. But sometimes these opacities would evolve rather than resolve. So in this patient, these opacities have evolved into dense consolidation in both the lower lobes, and in the left lower lobe, actually new consolidation patch has appeared. Also, another section from the same patient, this is ground glassing, just a bit of ground glassing peripherally, and now here you see some bit of consolidation with ground glass, and there is some peribronchial cuffing. And here I can see one bronchus, which to me seems to be slightly distorted, but we cannot really call it traction bronchiectasis at this moment. I would rather wait and let these other opacities resolve and then be able to comment whether this is true traction bronchiectasis or this is just peribronchial cuffing. So we have to make a distinction between the kind of abnormalities, and not all these abnormalities would represent fibrosis. So in a thorax article, George et al. Have presented another case where they have clearly shown that there is a patient with traction bronchiectasis appearing during the course of his hospitalization. And this patient, I would rather be careful during the follow-up, because a sign of fibrosis has already appeared in his radiologic imaging. This is another of our patients. I was very bothered about this patient because he had lots of parenchymal changes. He had a pneumomediastinum during the hospital course, and here I could see some cyst-like changes, which I'm not sure whether they represent just some kind of interstitial emphysema, or whether they are going to progress to airway-centric honeycombing. But even this patient was given just a medium dose of corticosteroids during follow-up. And at 4 weeks after discharge, he has improved from an MMRC grade 4 to MMRC grade 1 dyspnea. He's off oxygen. He's able to walk without any desaturation on the sit-to-stand test. And we have planned an HRCT at 6 weeks. This is another patient I would be bothered about because of the kind of architectural distortion I see on her CT scan. But this patient has also improved clinically over a period of 4 weeks, with MMRC grade 4 dyspnea falling to grade 2. She's off oxygen. She's able to walk without any desaturation on sit-to-stand test. HRCT planned at 6 weeks. This is one patient I would be rather more bothered. He just presented to us a week back. And here I can see some bit of distortion in this bronchus, and there's a lot of fine reticulation. And this kind of imaging, we have to be more careful, but still I would not like to label it completely as a fibrotic image. I would allow some time to pass and get a repeat imaging. And if these abnormalities persist or increase, I would rather favor the presence of fibrosis on the CT scan. So I just want to make a point that you have to make a distinction between all these kind of abnormalities that appear on the CT scan of these post-COVID patients. It's not just post-COVID fibrosis, it is post-COVID diffuse lung disease, which can be organizing pneumonia, or it might be fibrosis in a few of these cases. So there are a few studies which have reported CT scans being done at different time points in discharge. So if we look at CT scans immediately after discharge, a lot of them would have lots of ground glass opacities and patchy consolidation. But with time, these ground glass opacities generally disappear, but some interstitial thickening might appear. And some of these studies, which are indeed small, have reported signs of fibrosis, but they have not qualified what signs of fibrosis they have encountered clearly. So we need more studies, observational as well as clinical trials on this issue. The next chapter in my lecture is All That Glitters Is Not Gold. So if you look at the CT scan of one of our patients, you can identify this patchy consolidation. I've seen the other sections of this patient previously. So this is patchy consolidation, but here you can see these band-like opacities. And it is often interpreted as a fibrotic band. So this is often called a fibrotic band. So now moving on to the excellent study by the Chinese, which I previously showed. They also had encountered these fibrotic bands during day 4 of the patient's clinical course. But even this fibrotic band has disappeared with time on day 18. So how can fibrosis disappear? So what the explanation that they have proposed is, moving back to the CT of my own patient, you can see this fibrotic band, but it is just starting after a bronchus, which is cutting off here. Even this band, I don't know whether you can see, there's a bronchus which leads to this band. The bronchus, the small subsegmental or subsegmental bronchus gets cut off, and then this band starts. So there's a proposed explanation that because of mucus plugs in these smaller bronchi, this is all plate atelectasis, subsegmental atelectasis, which is occurring and which is resolving as the acute illness evolves. So all that we see on the CT image and interpret as fibrotic bands might be just atelectasis. So another good example, there's a bronchus, it gets cut off, and then there is a fibrosis-like band, which actually might be representing a subsegmental atelectasis. So a theory has been put forward that antifibrotics will benefit all post-acute COVID patients with pulmonary parenchymal abnormalities. Does this argument hold water? So I would try to analyze this argument. I do not really agree with this argument. The first counter that I put forward is that the histopathology of post-acute COVID lung is unknown to us. So it's still early in the course of this pandemic. Almost all studies of COVID lung histology are autopsy or postmortem biopsy studies. So the kind of pathology that has been encountered in severe cases who died during their illness and mostly after a prolonged course on mechanical ventilation with all the associated barotrauma, ventilator-associated pneumonia, etc., cannot be extrapolated to most mild to moderate and even severe patients who generally make a complete recovery and get discharged. The second counter I offer is the predominant patterns encountered even in these autopsy studies are rather typical of the usual ARDS that we have seen. So Dr. Ritesh has already told you that the physiology during acute COVID might not be different from the garden variety of ARDS. So autopsy studies done in patients. So this is one autopsy study. So some of these patients died early, before 14 days of their illness. And they showed mostly early exudative phase of diffuse alveolar damage and had the presence of hyaline membranes. Some of these patients have died in the mid stage, in the third or the fourth week. So they show the typical pattern of organizing DAD. So this is also a typical pattern which occurs in the garden variety of ARDS patients. But some of these patients have this fibrinous exudates or fibrin balls inside the alveolar spaces with numerous intraalveolar macrophages, and they might have an appearance of acute fibrinous and organizing pneumonia, which in several cases has a poor prognosis. So there's a lot of fibrin and organizing that. In the late stage, those who die beyond 4 weeks mostly have organizing or the fibrotic phase of ARDS in their pathology, where there is progressive interstitial fibroblast proliferation with sparse collagen fiber deposition. And microhoneycombing has been reported distinctly rarely in all these series. So it's mostly typical of the post-ARDS fibrosis that we have encountered prior to this pandemic. My third counter to the argument of antifibrotics is that the predominant abnormalities in mild to moderate COVID are unifocal and multifocal ground glass opacities and patchy peripheral consolidation. So this is a tale of two eras, the before corona era and that is the BC era, and the after disease era, that is the AD era. So before corona, I had this patient. You can even read the date from here. This is done in 2017, and you see this kind of a patchy consolidation, ground glassing, a reverse halo sign. And we used to call it organizing pneumonia classically. And we used to say that give this patient steroids. And the similar kind of CT that we encounter now with patchy peribronchial consolidation, some RHS, some ground glassing. And now we are trying to call it post-COVID fibrosis and trying to give antifibrotics. So why this difference? My fourth
Sajal, we can't hear you.
I think he has some network issues.
or I think the antifibrotic companies have done some problem here.
Can you hear me?
Yeah, loud and clear now.
Yeah, sorry. So it got muted, I don't know why. So my fourth counter is that antifibrotics have been proven useful in idiopathic pulmonary fibrosing ILDs. But there is a huge difference between the two types of illnesses.
Now I'm convinced that antifibrotic companies have done some problem now. Whenever he's trying to speak about against antifibrotics, his voice is getting lost.
It's just like what the news channels did to Trump. They cut off his address in between.
We have lost sir. Sir has logged out. Should we move?
The Kavina Creations, can you play the Sajal's slide? He will be presenting from my office.
Okay, sir has not shared the slides as backup, sir. So if sir could do the same.
Okay, so we'll just come back in a second or so.
Share.
Are the slides seen?
Yes, sir, we can see the slide.
Okay, so Sajal will present from my computer. I think his computer has been hijacked by the antifibrotic companies.
Okay. So my fourth counter, can you hear me, Kashish?
Yes, sir, we can hear you.
The fourth counter that I offer is that the antifibrotics have been proven useful in IPF and other progressively fibrosing ILDs. But there is a lot of difference between IPF and PF ILDs on the one hand and post-ARDS fibrosis, including the post-SARS fibrosis and the post-corona fibrosis. And the differences are that in IPF, there's a chronic progressive course, while in post-ARDS fibrosis occurs acutely. In IPF, there's an ongoing lung epithelial injury, while in post-ARDS fibrosis, the injury has occurred initially over a period of 3 to 4 weeks during ARDS, and then there is generally no ongoing injury. In IPF and PF ILDs, you would have parenchymal abnormalities that would keep on increasing over time. But in post-ARDS fibrosis, parenchymal abnormalities resolve or decrease over time. And in the previous SARS pandemic, studies have shown that these abnormalities keep on improving even over 1 year of duration. Then in IPF, there is honeycombing, which is the predominant radiologic and pathologic feature, while in post-ARDS fibrosis, post-SARS fibrosis, and post-corona fibrosis, honeycombing is distinctly rare. So my fifth counter is
that the antifibrotics take time to act. Pirfenidone needs dose escalation over weeks. Nintedanib, which does not require dose escalation, would also still require a few weeks for its actions. Post-COVID fibrosis, which occurs rarely, it still occurs over a 3 to week period. So will these antifibrotics act in that short span of time? And when would they require to be started for their actions to be apparent during this period of time? And another argument is that the generic nintedanib preparations that have become available in the Indian market lately are not maintained in a cold chain, while the innovator molecule has always required a cold chain. So we need to find out how this the generics are being stable at room temperature during the hot and humid weather of our country without requiring a cold chain. So there is a tug of war which is going on between experts at the international level. So some experts claim the usefulness and effectiveness of antifibrotics, that is the pro-antifibrotic band, and there is another bandwagon which is anti-antifibrotic. So they have put forth their arguments which are similar to my arguments that these antifibrotics may not be effective and might be potentially dangerous and harmful, especially when used during the acute and post-acute COVID stages. So there's an American proverb, once bitten, twice shy, and there is a business entrepreneur in America who has modified this proverb, and it now reads, once bitten, twice shy, and thrice shame on me. So once we have bitten, we have all been fooled and failed by experts in the management of acute COVID-19, and Dr. Inder Paul has shown ample evidence for this. So the claims have been HCQS would not allow the virus to enter the respiratory epithelial cells. IL-6 is the driver cytokine of COVID, so let us give tocilizumab, which finally has proven ineffective. Ivermectin kills the virus just as it kills the bugs on your kitten. Donor convalescent plasma will quicken your own convalescence. And the FAV, the favipiravir, which is claimed to be an effective anti-COVID drug. There's an Indian guideline on its use without any evidence for its efficacy. Even the remdesivir evidence is at best shaky, so what to talk about favipiravir. And the other FAV, that is the 15th August vaccine fiasco that we had. So we must be twice shy. The claim that antifibrotics will work in COVID, which has been claimed by several experts, should I believe it? Antifibrotics being used right, left, and center for all post-COVID patients at discharge in several hospitals in India. Is it the correct approach? I would not jump onto the conclusion that antifibrotics might work in all patients with post-COVID diffuse lung disease. But I also do not rule out the possibility that antifibrotics might work in a subgroup of patients with post-COVID diffuse lung disease. Because if I just rule out the possibility of the efficacy of antifibrotics, that would just make me as dogmatic as those who favor antifibrotics. What we need to do right now is to closely follow up these patients so that we know what is the course of the post-COVID fibrosis that has occurred in the post-acute stage, whether it progresses, and if it progresses, what are the predictors of progressive fibrosis. We don't have many studies on the predictors of fibrosis. There are a couple of studies on predictors of abnormal CT, but not on the predictors of progressive fibrosis. And even these studies have just listed predictors which just represent a severe disease during the acute stage and nothing more. So what should be the specific aims of COVID-19 follow-up? We must try to identify patients with COVID-19 who would go on to develop long-term lung sequelae without over-investigating those patients who will make a full recovery. So most mild to moderate patients who have not required oxygen during the hospital course generally do not require a very close follow-up or multiple investigations during the follow-up. We must address acute patients' needs such as breathlessness, oxygen requirements, rehabilitation, palliative care, and symptom management and psychological needs at the earliest possible stage. And we should focus this effort for only those patients who really require this kind of help, those who have significant morbidity at the time of discharge. We must reassure patients who have been diagnosed with COVID-19 pneumonia, but whose X-ray changes have either resolved or significantly improved, that they must not worry and they must not keep on repeating their X-rays and HRCTs in future. We must adopt a holistic management approach, which has been proposed by a few leading researchers, including in this article from Thorax, which includes assessment and management of breathlessness, oxygen requirements, rehabilitation, palliative care, and addressing other symptoms like anxiety, fatigue, cough, sarcopenia, etc. So this is the kind of algorithm which has been proposed in one of these articles. This is different for patients who have severe pneumonia, and another different algorithm has been proposed for patients who have mild to moderate pneumonia during the acute stage. So in those with severe pneumonia, we must try to get a consultation at 4 to 6 weeks after discharge. It might be a teleconsult, it might require a physical consultation, and at that time we can get a chest radiograph, which must be enough to just follow up the lung abnormalities, and we must try to get some kind of physiologic testing done, because many of the centers who are doing pulmonary function tests, including spirometry, are not running their services. We can just do a sit to stand test to look at the exertional desaturation, or a full 6-minute walk distance test to look at the change in the distance as well as in the desaturation, if that is possible. So if required, we must go ahead with a HRCT scan, which should be done only if there is a significant physiologic defect or the chest X-rays are showing persistent opacities, and then further follow-up of these patients can be planned according to the kind of course they have shown on radiologic imaging. So for mild to moderate pneumonia, we can get the first consult at about 12 weeks because they might not require an earlier consult. And this might also be a telephonic consult. If the patient has joined work, is fully active up to his pre-morbid level, we might not follow up too much, although this flowchart recommends a lot of other things. But what I would suggest is that if there is no physiologic defect, if there is no limitation of his routine activities, if the patient has come to the pre-morbid level, nothing else is required in mild to moderate disease. Now, how to treat? This might be the biggest question which might be expected out of me during this lecture, but this is the question which I really cannot answer at this stage. But I can put certain things into perspective, as I've tried to do during the course of my lecture, that because the most common pattern of abnormality during COVID is an organizing pneumonia-like pattern, the agent of choice to treat such kind of an abnormality should be a glucocorticoid, which can be prednisolone or other engineers. But this needs to be tested in a randomized controlled trial, because several of these patients might resolve spontaneously, just like other forms of viral pneumonia resolve over time, even without the use of glucocorticoids. But later in the course, and especially in those patients with signs of fibrosis, such as traction bronchiectasis, we should follow these patients very closely, keep on monitoring their physiologic function in terms of their activities of daily living, and we can adopt to use the sit to stand test or the 6-minute walk test to assess the level of exercise limitation that they are having. And if we document that these patients have progressed either radiologically or on spirometry, and this fibrosis is progressive, then we might consider in certain of these patients antifibrotic agents. Whether to choose pirfenidone or nintedanib still is an open question. No evidence for either of these approaches, but we do expect that such kind of evidence will soon be generated in near future. Finally, I work with a Shanti Swarup Bhatnagar awardee, Professor Ritesh Agarwal, one of my senior colleagues and mentors. So I cannot but have to get involved in some kind of research studies in post-COVID diffuse lung disease. So we have a prospective observational study of outcomes of COVID patients being done after discharge, where we are following them up for a period of 6 months. There's a retrospective multi-center study planned, which documents the use of antifibrotic agents for post-COVID-19 lung fibrosis or diffuse lung disease. Then there is also a comparative study of different glucocorticoid regimens for post-acute COVID, and a study of pirfenidone for patients with signs of fibrosis and progression after a trial of glucocorticoids in the late post-acute and chronic phase. So the take-home messages from my lecture are: several patients get discharged after acute COVID care would require ongoing care. Not all pulmonary parenchymal abnormalities that appear after a course of acute COVID pneumonia represent fibrosis. Most abnormalities like GGOs and consolidation resolve. Atelectatic bands must not be confused with fibrosis. We must focus efforts only on the at-risk patients who had severe disease during the hospital course and were indeed symptomatic and limited in their activities during discharge for the follow-up planning. Glucocorticoids might be useful for treating pulmonary parenchymal abnormalities in the early post-acute COVID stage, but further research is required on the dose and regimen. And antifibrotic agents might be useful for treating pulmonary parenchymal abnormalities with signs of progressive fibrosis in the late post-acute COVID and chronic stages, respectively. Further research is required in this area also. Thank you.
Dr. Sajal, your lecture itself had cleared up most of the questions, but still, since many people had asked similar questions, I would request you to make it clear regarding the follow-up.
Yeah.
A patient with mild to moderate disease coming for follow-up, would you order a HRCT? Similarly, a patient who had a severe disease required NIV, he is coming, whether a follow-up is required, how would you follow?
So patients who had mild to moderate disease during the acute course, those who didn't have hypoxemia, even if they had infiltrates on the chest X-ray, we would just get a chest X-ray at 6 to 12 weeks after discharge in these patients if they had any limitation or any symptom at the time of discharge. If they are absolutely symptom-free, I would rather not have any kind of imaging if at discharge the X-ray is not showing much abnormality. But for those who had severe disease during the acute illness, they usually at discharge would be having some or the other abnormality, and such patients need to be followed up closely. I would just get a chest X-ray at 6 weeks for these patients, and if the opacities are persisting, I would move on to have an HRCT chest also, because I fear that some of these patients may have either persistent abnormalities, or rarest of the rare of these patients might develop a progressive fibrosing kind of a phenotype later in the course. So only in these patients I would be very careful. But actually the HRCT scan is being overutilized during the acute course. So patients who do not have any symptom apart from just a bit of cough and fever are getting HRCT done. And COVID is such an illness where we are finding some kind of small patchy ground glass opacities, even in those patients who do not report any lower respiratory tract symptoms. And because of this over documentation of these opacities, the imaging gets repeated, which is not really required.
Since we are running already 20 minutes late, I think we can move on to the next lecture.
So I'd like to introduce the next speaker, Professor Ashutosh Agarwal, who is also one of my senior colleagues and mentors and the head
Matched
of
non-COVID controls 4 times in number for each asthma or COPD patient were also identified from the database in a nested case control design. Overall, the use of inhaled corticosteroids was not associated with higher odds of mortality. Use of inhaled corticosteroid was also not associated with increased incidence of COVID-19 among either COPD patients or patients with bronchial asthma. And odds ratio for asthma seemed much lower for asthma as compared to COPD. More recently, a large retrospective analysis from UK Electronic Primary Records has interrogated associations between current use of inhaled corticosteroids and COVID-19 related deaths in patients having asthma or COPD. In this study, in the COPD cohort of nearly 1.5 lakh patients, use of inhaled steroids was associated with an increased risk of COVID-19 related death after adjusting for relevant factors, with a hazard ratio of 1.39. This risk was significantly higher for triple therapy, but not for dual therapy. So this does suggest that this difference really cannot be explained by inhaled corticosteroid use alone. The authors also carried out some bit of sensitivity analysis, and they themselves suggest that other confounding factors, which perhaps are not attributable to the use of inhaled corticosteroids themselves, like disease severity, etc., may actually be driving these results. Also, this study excluded altogether the patients who were using LAMA alone. So this is a very kind of highly skewed data set from which these results were derived. The study also had an asthma cohort of more than 8 lakh patients, and ICS users were compared to those using only SABA. Again, a very lopsided kind of comparison. So hazards of COVID-19 related mortality were higher in high dose ICS users as compared to non-ICS users, with a hazard ratio of about 1.55. However, hazards of COVID-19 related death were not significantly higher in those prescribed low or medium dose ICS. This again probably indicates that ICS use had no bearing on COVID-19 mortality, and probably the underlying disease severity itself was the force that was driving all these outcomes. Overall, from both these data sets, the authors concluded that their evidence did not demonstrate either a clear benefit or a clear harm from inhaled corticosteroid therapy for either asthma or for COPD patients. Based on such evidence, guidelines from GINA, GOLD, and NICE, as well as other professional bodies like the British Thoracic Society or the European Lung Foundation and several others, they all recommend that inhaled corticosteroid use does not pose any additional risk, and therefore it should be continued as before. In a similar fashion, clinicians often consider biologics used for severe asthma to be immune suppressing. However, again, this is not borne out by the limited evidence that is available to us. There is some data from a Belgian severe asthma registry that has reported no difference in incidence of COVID-19 between severe asthma patients treated with biologics and patients not receiving any asthma biologic. Another multi-center retrospective analysis from the Spanish network of asthma also did not find any differences in terms of severity of COVID-19 ICU admissions or mortality. Hence, experts and professional bodies like the European Academy of Allergy and Clinical Immunology, they suggest continuing biologicals as before in those patients who have severe asthma. And finally, can patients distinguish asthma or COPD exacerbations from the respiratory symptoms related to the COVID-19 infection? This sometimes may be genuinely difficult given the overlap in their clinical presentations. However, the British Thoracic Society and some other experts too provide a general guidance on this. In general, we can tell patients that symptoms such as fever, tiredness, and changes in taste or smell are typically and much more commonly seen with COVID infection rather than in asthma exacerbation. So if patients have these symptoms, then they are more likely to be having COVID infection. Similarly, wheezing and a feeling of chest tightness are more likely during an asthma exacerbation rather than COVID infection. Of course, these are very, very general guidelines, but as I said, sometimes it may be genuinely difficult to distinguish a disease exacerbation from fresh COVID-19 infection. So to summarize, both ILD and COPD may be associated with more severe COVID disease and worse COVID-associated outcomes. Well-controlled asthma, especially the allergic or the Th2 high endotype, does not appear to increase the risk of either acquiring COVID infection or having poor outcomes. By and large, the treatment of chronic lung disorders should continue as before and as per the prevalent guidelines. We should try and reduce all non-essential contact with the healthcare system for these patients to decrease their risk for COVID infection. Since some of these conditions will adversely affect COVID prognosis, advocating preventive measures such as social distancing, use of face masks, and hand hygiene might prove to be much more important than taking decisions about modulating or changing therapy and so on. Thank you for your attention, and I hope all of you stay safe. I will be happy to take up a few questions. Thank you.
Okay, so what we'll do is we'll move to the panel and we can take up all the questions which are pending, as well as questions related to Dr. Ashutosh's lecture. So, so there's one question that why the Th2 driven asthma have a lower risk. And somebody has asked, do you believe they can have a therapeutic role in near future?
As I said, unfortunately, the evidence is too much sketchy. We don't even know how the Th2 dominant asthmatics actually lower their risk against COVID. And there is some suggestion that it might be driven through interferon mediated pathways. But then there are also controversies related to that. In general, we have currently no idea. This is just an observation that has come up from some of the studies that I have shown, and of course, this needs to be further looked into. There is also another thing that lot of the asthma that is not Th2 high, they are also these patients are more obese, they are more elderly, and it might be true that these factors rather than the Th2 endotype which is driving the adverse outcomes for these patients. So we are not sure what is really the cause for this.
So we had certain questions which have been frequently asked, so we'll include those. One is, what is the guidelines for managing COVID in pregnancy? Prasad, would you like to say something about that? Because this is a frequent question which I see in the chat. Yes.
Yes, sir. So, as far as pregnancy is concerned, what is heartening to know is that pregnant patients are not at a higher risk of contracting COVID. But unfortunately, once they contract COVID, the risk of severe disease, that is the risk of they being transferred to an ICU or risk of being put on a ventilator, is higher, just like the previous H1N1 pandemic. But fortunately, compared to the H1N1 pandemic, the mortality in pregnant women have been lesser. And the risk of preterm birth is higher, probably because these sick patients, physicians would try to conduct the delivery earlier to improve the pulmonary dynamics. And the risk of vertical transmission from mother to child, there is no clear cut transmission to the child. So there is no need for specifically conducting a cesarean section just for the sake of preventing transmission from mother to child. You can conduct a normal delivery. And even in infants who contract COVID-19 infection, most of them have a mild disease. And even after delivery, nursing and breastfeeding is encouraged while using hand hygiene practices and proper mask. There are studies which show that if mothers practice these measures diligently, the infants are very unlikely to contract infection. And regarding drugs in pregnancy, as we had already seen in Dr. Inder's lecture, only steroids are used, and they can be safely used in pregnancy. And in fact, they can help in lung maturation of the unborn infant.
What about managing COVID in the pre-op setting? It's a closed question, isn't it? So patients with the pregnancy will have may require cesarean and other things. And what about managing the COVID in the pre-op setting? So we have a lot of patients who come for some surgeries. So are we going to see some change in the management there in surgical setup?
So it is dynamic. Various societies have come up with various guidelines. The basic premise is that if the surgery is emergent and urgent, the surgery needs to be taken up immediately. Initially, people have been using preoperative CT scans to diagnose RT-PCR negative cases of COVID. That practice is not recommended. So in an asymptomatic patient with the COVID negative, we can go ahead. But the policy of postponing elective surgeries is with the idea that the elective surgeries take up hospital resources, including beds, staff, and PPE. So in high transmission areas, they recommend that if there is a decreasing trend consistently for 14 days, then you go ahead with rescheduling of elective surgeries. Otherwise, elective surgeries can be delayed, and only the emergent and active surgeries needs to be taken care of with the standard precautions required for COVID negative patients. In this, yes, sir.
Wali, when are we going to stop doing COVID testing before procedures?
Sir, if the community transmission is significantly decreased, we can. But I think this is $1 million question, and I don't think I deserve $1 million.
We do it in several places. The anesthetist asks for COVID testing of 48 hours. So suppose the patient has some hypertension, gets delayed, is in the hospital for 48 hours, and he has to get another COVID test. And there was a joke that the patient came with the arrow. They said, yeah, I think the diagnosis is accidental. You have been struck by an arrow, but please get a COVID test. So when is this COVID testing going to go away?
Yes, sir. I do not have the answer for that question, but there might be some rationale for the 48 hours concept, because there is one small study from Wuhan which will include only 34 patients who were asymptomatic and were probably incubating at the time, and in the post-op period, day 1 and day 2, they started developing COVID symptoms. Unfortunately, in these 34 patients, half of them ended up in ICU and 20% of them had survival. But this is a retrospective data, and the only evidence from the asymptomatic patients.
So you say 48 hours, final message.
If it is urgent, take precautions and go ahead. If it is elective, then wait.
Okay, then I think we have to go ahead with doing this. There's a very important question for Inder. Inder is a lead investigator in a experimental therapy, which is Mycobacterium W, also known as Mycobacterium indicus pranae. Inder, the world wants to know what is the role of MW in COVID-19. There was a lot of hue and cry and a lot of news items on MW and COVID. So Inder, please.
So like all investigational therapies, I would suggest that initially when we had no evidence, we had no drug to give, people have used off-label also, but once we have evidence that steroids do work, all investigational therapies, including MW, should be used only under clinical trial setting. And we've just concluded a clinical trial which included 42 patients. That's the initial interim analysis, which we will publish. But till we publish the results, should not be used out of clinical trial setting. The use of MW did have some rationale behind it, because just like gram-negative sepsis, COVID viral infection also has a dysregulated, is in fact a dysregulated immune response to viral infection, which by definition fits into any definition of sepsis. So that was the rationale behind using MW in viral sepsis. So let's see what the results show us, but till we have results, we should not be using it left, right, and center. We have published initially the use in 4 patients where we have seen that it was not doing any harm. We don't know whether it will do any good or not. That only the trial.
I think this answers the question of a vast majority that MW is an experimental therapy. We are evaluating it in an RCT, and there is currently no role for routine use of MW in COVID unless the patient has gram-negative sepsis, where it has been shown to be beneficial. So Sejal, I think a lot of people are waiting for your this one, that you have not disclosed your conflicts with the Boehringer and so on and so forth. So before, so I think you disclose the conflicts and you say what is the role of, what do you think in very briefly the role of antifibrotics now in post-COVID lung involvement?
So my conflict with my involvement with Boehringer Ingelheim is in the form of a co-investigator in a regulatory trial. And mostly during the course of my lecture, I have acted as an anti-fibrotic gang member. So I may also be called a pro-fibrotic cytokine. But anyways, during acute COVID, I have presented a lot of reasoning based on logic and scientific evidence that during acute COVID stage, if fibrosis is going to occur in some of these patients, a very small proportion of the patients who would finally undergo fibrosis, the fibrosis would occur very early. It will occur in the first 3 to 4 weeks period itself. So if you are going to use antifibrotics, they might not have that much duration that they need to act, even if you start that agent on day 1. And the problem is that we don't have any predictors till now in which using which we can say that this patient who has presented to us today is going to develop fibrosis 3 weeks, 4 weeks, 5 weeks down the line. So there is no rationale to start antifibrotics during the acute COVID period. During the chronic phase, I have already presented that most of the abnormalities resolve with time. Most represent organizing pneumonia or kind of non-specific interstitial pneumonia, and these abnormalities are usually treated with corticosteroids. But if some of these abnormalities do progress to signs of fibrosis like traction bronchiectasis, we also have to document that it is progressive. So if it is not progressive, we are not
there is
bothered.
no current role for routine use of antifibrotics. I think that is one clear message from the lecture, which Sejal has said. And only if you document fibrotic changes on the CT, only then. Plus, what do you think in patients who are asymptomatic, who have been routinely being followed up with CTs? What do you advise?
It should not be done. Patients who are asymptomatic, who are mildly symptomatic, who are maintaining their saturation at rest and even on exertion, they should not undergo even CT scan during acute COVID, not even a chest X-ray. Even a chest X-ray is not required in a patient who is absolutely having mild fever, some cough. He does not even require a chest X-ray.
Guys, if you're using antifibrotics, it's poor medicine in nutshell. For Dr. Ashutosh, sir, do you think there is increase in non-COVID mortality in the COVID times? It's a very important question because of all this, everybody asking for COVID testing and everything, all the procedures getting, delayed and so on and so forth. Do you have any? Are you aware of any data which reflects that there is an increase in non-COVID mortality?
There is likely to be an increase in non-COVID mortality because of the restriction to proper healthcare access. So like OPDs are shut down.
The incidence of coronary heart disease went down. There were hardly any CATs which were being done when there was lockdown. It looked as if all coronary heart disease have disappeared from the face of earth.
So only the unnecessary CATs went down. I'm sure patients were dying even without having CATs, and they still continue to die. So it is definitely because the access to healthcare was not proper. So the mortality would have occurred. It's just that it's not being reported. And specifically in the context of pulmonary disorders, I think one of the biggest losers has been tuberculosis. In fact, there is now a lot of data which across the world which suggests that the TB patients, they missed out on their doses. They could not go to DOT centers. There was a rapid decline in the notification of new TB cases simply because these patients were not reporting for diagnosis or for confirmation of their diagnosis. So we've also collected some data from the NICSHE database, which is the official database for TB numbers in India. And it clearly shows that as soon as the lockdown got implemented, there was a precipitous fall in the number of TB notifications. And although during that lockdown phase, the notifications did go up by a small fraction, they were nowhere near the corresponding numbers in the previous years. Normally, we would expect that the numbers in the current year will go up. They will exceed the previous year numbers. But a consistent gap has been always maintained between last year's data and the current data. So definitely, there are a lot of missing patients. For TB, we have this data officially, but I'm sure that for a lot of other disorders like say asthma, COPD, stroke, cardiovascular diseases, this data is simply not there. Most of us are not running our OPDs as we used to normally. And the missing patients are still there in the community. Either they are taking some treatment from local practitioners or from quacks or from WhatsApp groups, whatever. But the morbidity and mortality is certainly likely to be there. And this is the biggest fallout that we have seen from COVID.
Inder, what is your take on vasculopathy in COVID? And the role of anticoagulants. You can just briefly summarize because a lot of people are still not clear about anticoagulation use in COVID.
So, I had clearly shown that our practice of using anticoagulation in COVID should not differ from what we do routinely. Although there is a higher risk of thrombosis in these patients, currently we do not have evidence to suggest that a higher dose of anticoagulation, that is the therapeutic dose, would reduce the chances of developing venous thrombosis. Rather, it can increase the risk of GI bleed, which may require blood transfusions also. And this is what I personally have seen in few of the patients where I have been involved in the management. Another frequently asked question is whether we should give extended thromboprophylaxis after discharge. Again, the answer to that question is that if you feel that patient is going to be bed bound and have restricted movements within the house and has a higher risk of developing a thrombosis, for example, he's got an active malignancy, then yes, you may consider giving him an extended thromboprophylaxis. But while in hospital, all acutely ill and critically ill patients should be given thromboprophylaxis with the routine dose and not with the intermediate dose or therapeutic dose. And there is definitely no role of low dose thrombolysis.
Sejal, is the drug therapy for COVID different in chronic liver or chronic kidney disease?
No, sir. Actually, the overall management of COVID-19 during, if somebody has a chronic renal or liver disease, would be very similar to the kind of critical care management that we offer to these patients. But because the drug therapy mainly involves steroids, we just need to weigh the risks and balance of the increased infection risk that occurs with corticosteroids during the management of these patients. Otherwise, mostly dexamethasone 6 mg has the evidence for its efficacy.
People have come late, so they didn't listen to Inder.
So Inder has already.
Therapy which works is Dexa.
Yeah.
Remdesivir is plus minus. Plasma, tocilizumab, favipiravir, ivermectin, azithromycin, doxycycline, zinc, vitamin C, ivermectin. I think I have not missed anything. They all do not work. So I think the only therapy which works is steroid. So steroid and remdesivir and chronic liver disease and chronic kidney disease.
So once you have clarified this, the question becomes very easy because I don't need to remember what kind of dose modification is required for favipiravir, remdesivir, and renal and kidney disease, renal and hepatic disease. So it's just steroids, and they can be used in the dose which has been used because it amounts to just 40 mg of prednisolone. For this short use at this dose, no dose adjustment is required in renal or hepatic disease.
I think that answers the question. IP, we have one question for you. Vishwanath has asked that, let's say a patient is on HFNC. If I have to 0.7, he is okay. He seems to be okay. Respiratory rate is about 25-30. When will you move to the next level? You want to take up or should I answer? In that first you try and then I will try to answer this.
The most important thing for monitoring any patient of COVID is that if you just see the respiratory distress. If he's comfortably breathing, he is not in any sort of distress, he's not using any active muscles of inspiration, then you can observe him. There is no need to intubate that patient. But he is breathing with a very vigorous effort, he's likely to harm himself. Then you should in fact step up the therapy, first NIV and then perhaps intubation. One thing that you can do on HFNC is see the ROX index, which in one paper they have done at 2 hours. If the ROX index is less than 5.4, the patient is likely to benefit by elective intubation or escalation of respiratory support rather than just continuing with the HFNC.
Let's say
if the patient is comfortable.
Let's say the patient is doing okay, but he is not improving. He is continuing to maintain this at 4 days, 5 days, 6 days, 7 days. When will you move? Do you think that you should move to the next level at all? Or will you continue that for weeks together?
So what I have seen in limited experience that some of these patients would continue to be on this form of therapy and they actually would come out. Some of these patients benefit after just taking them up on NIV intermittently. And but if the respiratory effort is vigorous, then I don't think we should
I think that is a very important
time,
point.
and the time that one, you say whether 72 hours or 5 days or 6 days, I don't think I can answer that question. But what I have seen is that some of these patients can be just managed on HFNC or NIV, provided they do not worsen in their respiratory.
I think that
I would come in. I would like to come in here, sir. The high flow nasal cannula, although it has its own advantages, some very good advantages it has, but it has also become a kind of a false comfort zone that is being afforded to physicians because it delivers a very high FiO2, just like a non-rebreather mask does. And in illnesses such as ARDS and even COVID, the PEEP offered by NIV might help to recruit the lung, as we have already told in your lecture. So whenever the oxygen requirements goes up beyond a certain level, mostly 40-50%, we must try to switch to non-invasive ventilation in that stage, so that we can assess whether PEEP is going to help this patient, whether he's getting recruitment at this stage, whether his FiO2 requirement is coming down with the starting of PEEP. And once the patient is lingering on NIV and having, obviously when the patient has NIV, the NIV gets removed so many times during the day, and the actual use of NIV is just a proportion of the entire duration of the day. So during that time, all kinds of recruitment, de-recruitment injury will keep on occurring. So after a certain time, maybe 3 days, 4 days, again, I don't know the exact duration.
The art of medicine, it is not pure science as such, it's an art of medicine. So the important the point here for the audience is if the patient has respiratory distress, breathing pattern is not good, then it is time to move to the next level. Otherwise, you can observe. And like Sejal has put, there has to be some window period, 4 days, 5 days, etc., with which we need to move to the next level.
And I can put forward my hypothesis also, because I'm looking at post-COVID fibrosis. So certain things like prolonged use of NIV with recruitment, de-recruitment injuries going on for a long time, this kind of atelectotrauma as well as barotrauma, that might be a risk factor for the prolonged course and final fibrosis. And another thing which I would like to point out is even tocilizumab has been proposed that because it counters certain cytokines, including IL-6 at an initial stage, that might be counterproductive and might later in the course lead to a greater amount of fibrosis. So all these theories are also doing the rounds.
Also, I would like to add that suppose if the patient's requirement of FiO2 on HFNC continues to be 100%. So I have seen patients being managed on 100% for days together. That should not be acceptable. At the most 0.6 for a few days, you can prolong, but not at a level of 100%. There you should definitely, I think, electively intubate, even if the respiratory efforts are not that bad. That's where I would.
Mechanism of happy hypoxia, I'll just take that question. Happy hypoxia was always there. Even in the pre-COVID time, it was there. Happy hypoxia is due to the fact that the patient has a PCO2 of 40 or below. So at that time, the hypocapnia, which is defined as PCO2 of 34 or below, does not, kind of incite the breathlessness. So that is the reason why patient does not perceive breathlessness, and you find that the patient, despite being having a saturation of less than 90, does not complain to have dyspnea. The other reason is if the patient is febrile, then what happens? The oxygen dissociation curve shifts to the right. So there's a discordance of almost 9.5% saturation. So that is why if you do a PO2 at that time, the PA2 will be normal, but the SPO2 will be low. So that is the reason why the patient seems to be apparently happily hypoxemic. But that is a myth, and there are several articles on that issue from Professor Martin Tobin. If people require, you can email me at riteshpj@gmail.com, and I'll be happy to provide those articles. So there are a lot of other questions. I think role of methylene blue and Regeneron in COVID. I think all those things are not required at present because they are not relevant to us unless we have trials. So if there are, is there any other pressing question which I have missed?
There's one question regarding management of post-transplant patients and others who are already on immunosuppressive agents. So whether they are at risk.
That question.
So we've seen a couple of patients who have had renal transplant coming up to us, out of which I would say that only 2 or 3 patients had hypoxia. One of that patient, the hypoxia was attributed to a secondary infection like PCP, and we treated PCP. Unfortunately, she recovered from COVID, but she died of PCP ultimately. Only one patient died because of COVID, perhaps, and the treatment principles would more or less remain similar. So if the patient is not hypoxic, we did not give those patients any steroids, any remdesivir, nothing. We just observed them in hospital and they were discharged subsequently. What generally the nephrologist would do is they would stop all the immunosuppressive therapy and just continue with 10 to 20 mg of Vicelon just to prevent graft versus host reaction. That is what is the general practice during any infection in any kidney transplant patient or any other transplant patient for that matter. We also had one post-cardiac transplant.
D-dimer.
Don't do anything.
Many of my cardiology friends in Chennai, they do D-dimer. Every alternate day, if it's increasing, you say, no, give Clexane for long term.
So there is no evidence that measuring D-dimer would change the form of therapy. Some of these societies suggest that using a cutoff of 6 times the upper limit of normal, you may choose to use intermediate dose heparin, which is twice daily dosing rather than once daily dosing. Some suggest a cutoff of 3000, but in one small study which I had shown, baseline D-dimer levels did not predict whether you would develop thrombosis or you will not develop thrombosis.
Yeah, I think another important message which many people, those are logged in recently, there is no role of TOSI. Please don't use TOSI. Please do not use plasma. They are all therapies which have no evidence and they may be harmful also. Sejal, would you like to comment on post-COVID fatigue and post-COVID cough? Several patients have this post-COVID fatigue and post-COVID cough.
So post-COVID fatigue, we should approach it like any other complaint of fatigue. So it may be caused by certain physiologic abnormalities like anemia or hypoxemia, which might be occurring during exertion in these patients. And it might also be associated with depression. So we first have to find out the cause of fatigue. If we do not find any such cause, then what I try to do is to find out whether it is associated with significant myalgia. So if there are significant myalgias, then I try to offer the patients with some kind of paracetamol or NSAID if there is no contraindication. But if there is no definite cause linked to it and there are no myalgias, then that fatigue is really difficult to handle. And for that, what things have been offered for things like chronic fatigue syndrome and sarcoid-associated fatigue in terms of cognitive behavioral therapy and some kind of exercise therapy, which can improve these symptoms. But things like methylphenidate and modafinil should not be used.
What about vitamin C and zinc?
Yeah, it is a good chewy tablet, so you can always chew vitamin C. But I don't think it will help. It's a tasty
question for you. What is the role of sex hormones in management? It was asked by one of one of our participants. And Dr. Dharmesh also feels a very important question and it should be taken up.
It has been used for sarcopenia in the past, and these patients who have prolonged ICU stay also suffer from sarcopenia, but they have an important side effect in terms of inducing a procoagulant state. So I do not think it is a good idea to use them in these patients.
The thing is that some of these patients in whom we suspect a reinfection, so for example, one patient got all right and got discharged 4 weeks or 2 weeks down the line, gets readmitted. There you should think of secondary infections because most often these patients would have been given a cocktail of high-dose steroids, tocilizumab, and other immunosuppressive agents. You should always suspect secondary bacterial infections or they might be developing some fungal infection. Don't think that they are having reinfection.
And somebody has asked, how will you say it is reinfection versus existing infection which is going on? So you will have to type the virus there. There is no other way of doing this. Somebody asked, what is the role of immunosin alpha? I really don't know. What is this immunosin alpha?
I don't know.
I have really no idea. What is this immunosin alpha? Galaxy C9 Pro. Can you please tell what is this?
Maybe interferon alpha. Huh? Most likely. Could be interferon alpha.
So interferon alpha, etc. has no role.
No,
repurpose
sir.
that?
I just Googled it. It is immune booster of locally made, and I'm not sure as to where it is. Thymoglobulin. It's thymoglobulin. Someone has said.
And what do you think, Valli? You can take up this one also if you're Googling. What is the role of this Chwanprash and Ashwagandha and all?
Sir, I think I would add that to the vitamin C and zinc list where Dr.
Okay.
I
Sehgal
think
just now alluded to.
that is not the purview of this panel.
Okay, that says
Discussing
it all.
Ayurvedic, homeopathic
We
medicine.
added it to vitamin C and zinc list. Fine, Valli. I think that is I think we have taken up most of the questions. I have just final two questions, one for Dr. Ashutosh and one for Prasad. Dr. Ashutosh first. So do you think that we should be changing our PPE kind of, in my personal opinion, we are overdoing this PPE business, and is a major reason why patients are we are not able to manage the patient, because if you wear so many layers, you are sweating and you're not able to, your spectacles get fogged and so on and so forth. Do you think the PPE should change now that we have significant understanding of the disease?
Yes, I definitely think so. We need to be much less restrictive than what we are. In general, what we have seen at our place and even at other places, people don't want even 1 square millimeter of skin to be showing. So they'll put all kinds of sticking plaster and
I think that
add
was because
multiple
of the
layers
sensor.
of PPE.
I think this was a sensor issue, sir. The sensor said no skin should be shown.
So the downside of this is that you sweat a lot. There is a lot of fogging, and it is so uncomfortable to be in this kind of PPE for a 6-hour or a 8-hour shift. I think it's virtually inhuman. Unlike Ebola or some other viruses, this is not a virus that spreads by contact, and therefore all you need to do is to take adequate precautions that the aerosol does not, you really don't breathe into that aerosol, which means that you require a face shield and you require a tight fitting N95 mask. These are, to my mind, the most important things. You obviously can't wear your clothes into the ward or the ICU, so probably hospital overalls are a better option there. You change into hospital overalls, you finish your duty, you come back and you throw them for autoclaving or something, and you go back and have a bath. So that will allow you much more flexibility and comfort while you are doing your duty in the ICU or the COVID ward, without really compromising on your safety. The excessive use of PPE does not really compromise on your safety. It compromises on the patient safety, because you're not able to monitor them as properly as you would otherwise be able to do if you did not have so many layers. So I definitely agree that we should go down.
If there are no pressing questions, one final question is a kind of a sentimental and a kind of emotional kind of question for Prasad. Prasad is a very good speaker, orator, and thinker. Prasad, do you think will we ever be able to go back to the pre-COVID times?
The BC era.
Yeah, the BC era.
Tough question. The way I understand,
a closed door meeting of beer with Dharmesh and so on and so forth. Do you think will we ever be able to go back to such pre-COVID times?
So the way I understand this question is that we'll be in the pre-COVID era. We are roaming around happily without any worry of COVID. So that will happen only if we are immune to COVID. So that can happen by two methods: either a significant proportion of our population develops herd immunity, or which can be done either by the natural spread of infection or by vaccination. As we have seen, allowing the infection to spread is a very costly affair. So vaccination would be the best bet. But again, we know very little about the immunity, whether it is cell-mediated immunity or whether it is humoral immunity, which is important for COVID. Whether the antibodies which we are seeing, whether they are actually protective, that we don't know. And how long this antibody lasts, and the effect of vaccination, how long will it last, how many booster doses will be needed. So a lot of questions remain. So unless these are answered, it's very difficult to
Prasad, this is it looks quite
Plus
political.
ultimately we'll land in a zone of fatigue. The kind of feelings that we had when COVID was introduced in India, ये हमारा क्या उखाड़ लेगा? So ultimately, I think that kind of feeling will set in maybe in a few months or a couple of years for now, and at that time maybe we can move on as we had maybe till last year. But short of that, I think the masking and the social distancing is and all these virtual meetings and I think these are here to stay. This is a trend that is unlikely to get reversed in the near future.
Sir, what do you think is the community transmission in India now, sir?
I think you should ask directors of premier institutes.
Okay, I think we have answered most of the questions. I don't see any. There's some question. One, somebody is stuck on that post-COVID cough. Dr. Sai Ramya Gonuguntla. I think we have to answer a question. I think I have not much experience after Ascor LD. Most of the time I tell the patients to do deep breathing exercises, do some lom vilom and all those things. But I think Sejal can take up this question. If the patient is not responding to antitussives, what can we do, Sejal? Because you see a lot of such patients who have refractory cough in ILD.
So I sometimes combine antitussives I generally use dextromethorphan lozenges, which can be used in quite high doses, higher than the usual doses that we use, and other antitussives. But what he is trying to ask is whether steroids will be useful in this case or not. But we really don't know whether steroids will be useful just to tackle the cough. The mechanism of cough may be similar to that seen in diffuse lung diseases, but all this needs evidence. So I think it will be just hit and trial of the usual agents that we use for cough. For ILDs, we sometimes use thalidomide. So I don't know whether it is going to act here or not. Everything needs to be evidence-based, and more evidence needs to come for all this. But it will be hit and trial till then. Like inhaled ipratropium, inhaled salbutamol, and all those things, the usual agents that have been used for cough.
I think we have answered most of the things. Somebody has said, what is the role of steam inhalation in prevention? I think one of my friends also had this hypothesis.
So that is there amongst the participants.
Yeah, friend is there. Yeah, I saw his name.
So steam inhalation has been used often in upper respiratory tract infections, in mostly chronic infections. For example, if there is sinus congestion, in those infections, it may be useful to just for decongestion. But acute COVID does not have that kind of pathophysiology, so steam will not help mostly in this particular illness.
I think
plus the antiviral effect of steam is at temperatures which are unphysiological. So you practically will need to inhale at 100 degrees centigrade plus, so that by the time it equilibrates with your mucosa, it is close to about 70 degrees. And the COVID will be burnt out as well as your pharynx. So
I think that says it all. Okay, I think the questions will go on. The participants have kind of decreased by half. There are some more enthusiastic participants who are there. Is there anything else the panelists would like to say? Inder, what is our outcome in the COVID hospital? What is our outcome?
We had 2,000 patients who were admitted, and we have an overall mortality of around 15%. Amongst those who were critically ill and got admitted to the ICU, we have a mortality rate of around 30 to 40%. That's what our outcome is.
And what is the mortality on mortality of invasively ventilated patients?
So that is very high, which I attributed to a delay in intubation, which perhaps we would change.
I think that it is. Yeah. So I think we have discussed most of the questions. If anybody has anything else, then we can take. Otherwise, I think somebody is stuck on mechanism of development of pneumomediastinum, surgical emphysema, pneumopericardium without pneumothorax, and the use of NIV.
It happens. It used to happen even earlier also in acute interstitial pneumonia. especially in those who had dermatomyositis related ILD. So I think it is just a barotrauma at the alveolar level, which can be managed conservatively and needs no active intervention.
Okay, then I think we have answered most of the questions. If there are any other questions, we are available on our emails. You can email us. You can or email it to me, Ritesh PGI. That's easiest to remember. ritshpgi@gmail.com. We'll try to answer your questions there. It's getting late. It's a Sunday afternoon, and it's time for my afternoon beer. So I think we should call it a day. I think I hand over the mic or whatever to Dr. Ashutosh for the final comments.
So really no final comments. It has been quite a good discussion that we have been able to generate, and I'm happy to see that as a team we have been able to look at the evidence and kind of synthesize it and bring out salient points, not just for evidence sake, but points that are likely to alter our management. And more importantly, we have tried to focus on what we should not be doing. I think it is equally or perhaps even more important to be aware as to what you should not do to harm the patients. And I think the biggest gain, I believe, to our participants would be that some of the stuff that we have discussed is likely to be practice changing for all of us. And as with every other meeting, even we have learned from the comments, questions, and the discussions, and also from the review of literature that we carried out while preparing our own presentations individually. So overall, it's been a good experience for all of us, and I hope the participants will go back much more enlightened. So thank you all for your participation, and once again, a thank you also to Messrs. Boringer for helping us out logistically and financially with this